Good morning, everyone. We're going to get started. I'm Congresswoman Robin Kelly, and it's my pleasure to welcome you to today's Congressional Black Caucus Health Braintrust and Reconciliation Commission on Health Equity. Today's commissions will focus not only on understanding the root causes of systematic disparities, but also, and perhaps more importantly, where do we go from here? It's no secret that persistent, shocking, and really just horrible health inequities continue to plague our community. But it's one thing to talk about the numbers, and it's quite another thing to talk about finding real, actionable solutions to get people health care and ensure that no one dies because of where they live, their zip code, their race, or their gender. I believe in a solutions-only mindset when it comes to tackling these difficult challenges. In fact, I've been hosting several solution-only inquiries in my district using this model. The rules are simple. No finger pointing, no name calling. Come to the table with solutions or just listen quietly. And you know what? It's been working. We've been able to get people from different points of views to sit down, work together, and work through issues to find real solutions that work in our community and solutions I can take back to Congress in the form of legislation. While we absolutely need to understand the context and history to inform our solutions, I am interested in moving forward. I am interested in saving lives. And we must eradicate health disparities within our lifetime, not our grandchildren's. Today's Truth and Reconciliation Commission will help us along that road. Previous conversations on these topics, men's health, maternal health, sickle-cell, and HIV AIDS, have already informed the Affordable Care Act, the greatest leap forward on health equity in at least a generation. But there's still much more to do, and you know that we can do, and many of those elements encapsulated in a bill which I greatly believe in, the Health Equity and Accountability Act, affectionately known as HEA. HEA was introduced by me in the last Congress, and I'm honored that my colleague, Congresswoman Barbara Lee, has introduced it in this Congress. It is the product of intensive coordination and cooperation between the Congressional Black Caucus, Congressional Hispanic Caucus, and the Congressional Asian and Pacific American Caucus. If the ACA was the first step, HEA is the second on our journey toward health equity. Unfortunately, our Republican colleagues have yet to schedule a hearing on this important bill, but we hope to change that in November. And any of you who have Republican representatives, you need to call them on the phone and tell them we need to get this done. While HEA is truly the comprehensive step forward that we need, today's commissions will show that some areas still need special and additional attention. We'll discuss 4 of them: sickle cell disease, maternal health, men's health, and HIV AIDS. Before these specialized commissions begin, I want to highlight a few key points on each of the topics. First, sickle cell. This disease affects more than 4 million people around the world, and 1 in 13 African American babies are born with the trait, meaning they have the potential to pass a trait or the disease on to their children. So this really is a health challenge that affects all of us. You likely know someone living with the disease or the trait. Whether or not they know they are a carrier is a completely different story. Thankfully, new training and resources have become available for early tests and education, including of healthcare providers, and thanks to persistent work from the Congressional Black Caucus and its members on the Appropriations Commission. While we are making baby steps, we need to be making major leaps forward. I hope that today's commission pushes us to reignite a bold commitment to advance real solutions to address the end of sickle cell disease. Second, HIV AIDS. While many people think HIV ended with the era of hairbands and snap bracelets, I know some of you don't even know what I'm talking about, it's still around and it's still having a devastating impact on our community. While we've made some real advancements in treatment and prevention, which will be discussed a little later, we are at risk of seeing the epidemic rebound out of control, especially in our community. A recent UN AIDS report showed that with the right investments, we can see an AIDS-free generation within our lifetime, but it also warned that a failure to make these investments risk allowing the epidemic to rebound out of control. We've come too far to let that happen. We have a chance to finally end this epidemic, and we need to take it because the alternative is unacceptable. And any path to ending this epidemic must run through the African American community, a community that continues to disproportionately suffer from this virus, especially gay and bisexual Black men, Black trans women, and heterosexual Black women, especially those living in the South. Out of the top 10 communities with the most cases of AIDS, so many of them are in the South. New Orleans is number one, and I believe Baton Rouge is number three. Even Orlando is high on the list. And because of this marked impact in the South, I'm glad that my friend and my wonderful colleague, Congresswoman Terry Sewell of Alabama, will be joining us for the HIV AIDS Commission later on today. Third, maternal health. For a little over a year, it's been nearly impossible to pick up a paper without finding an article about this growing crisis, a crisis that's affecting Black mothers at 3 to 4 times the rate of white mothers. Across the board, American mothers are needlessly dying. In fact, it's more dangerous to have a baby today than it was 25 years ago. How did that happen? And it's a crisis that cuts across class, education, and income. Serena Williams, a world-class athlete who can afford the best health care in the world, had a near-fatal run-in with maternal morbidity. How many other Black moms are dying but not making headlines? How many more suffer severe and lifelong health complications due to maternity complications? And how many kids are growing up without their moms? It's time to turn those numbers in the other direction, and we know how to do it. For example, maternal mortality review committees are a great place to start, and every city and state that has implemented one has seen the numbers come down drastically. That's why I introduced the MAMA Act, legislation that takes a comprehensive approach to ending maternal mortality, including by establishing a national review committee to save mothers' lives. I firmly believe that this is a health disparity that we can turn around this Congress before the midterm elections. There are several good bipartisan bills on the topic in addition to my MAMA Act. We just need to get hearings and votes scheduled because everyone is already on board. So call those folks to tell them to get it on board. No one, whether from a blue state or a red state, wants to see mothers dying needlessly and kids growing up without moms. So let's do this. Let's get it done before another family has to live that tragic reality. And finally, the last commission today will cover men's health. As someone who's had to fight with loved ones to get them to go to the doctor, including my doctor husband, and take care of themselves, I know that sometimes men could be a little stubborn. But their health matters, especially when they have people depending on them. Unfortunately, we sometimes overlook the health issues that affect men, from mental health to prostate cancer and everything in between. I hope that today's commission can focus on the medical challenges facing men in our community, in addition to examining effective strategies to end the stigma associated with men seeking health care. Now I know that's a lot of issues to discuss and a lot of topics to cover, so we should get started. But first, I'd like to give the host of these commissions, Dr. Garrett Puckrin of the National Minority Quality Forum, an opportunity to speak. And I just want to thank Dr. Puckrin so much. He's been such a great partner to the Health Braintrust, which I'm the chair of, and we just appreciate you so very much. So Dr. Puckrin, join us.
Good morning. It's always a great pleasure to partner with the Congressional Black Caucus Braintrust and Congresswoman Kelly. They are moving sun and earth to eliminate some of the disparities that face our community. I want to take 2 seconds for those who don't know the National Minority Quality Forum, to tell you a little bit about our organization and some of the programs that we're doing, and then thank some of the sponsors that have helped us along the way. So the National Minority Quality Forum, we have focused on data collection. We've been collecting health data since 1998. We've built a database of 500 billion patient records. We collect over 100 million lives a year. One of the things that is not well appreciated is that there are 38,000 zip codes in the United States. 70% of African Americans live in 2,500 zip codes. All of this disparities that we're talking about is actually occurring in 2,500 zip codes around the country. What we've been doing is collecting data on those 2,500 zip codes. So we can take every African American in the Medicaid and Medicaid program and link them to the physician who's providing care. We know what prescriptions those physicians are giving. We know if those patients went to the hospital, the emergency room, the pharmacy. We know what they paid out of pocket. And we've been using that data to do interventions down at the community level. One of the programs that I'm proud of that we're starting to work on is a Sickle-Cell program. We're mapping sickle cell disease and understanding exactly where the sickle cell population resides and who's providing care, and looking to create partnerships down at the community level. We're doing similar work in vaccines, in diabetes. We've been working with Vice President Biden's cancer initiative. So we've mapped cancers, all of the cancers down at the community level, and then doing programs. So I'm really excited about that. One of the things that we've learned as we've been living in the data is that health policy is the new branch of medicine. If you don't get the health policy right, even though we have all of these new and fabulous technologies to help people live longer, they won't have access. And one of the big issues, certainly in the African American community, is access. And so what we've pledged to do is we're forming a health policy alliance that will use our data, our relationships, to try to make sure that African Americans have access to best modern therapy. Another program that I'm excited about, and some of you in this audience should be excited about, is our 40 Under 40 program. Every year with Congresswoman Kelly and the Congressional Black Caucus, we recognize 40 individuals who are at the top of the health profession. These are our future leaders. And so there are cards around. If you're one of them, you should pick up one of these cards and send us your resume. It's obviously a competition, and so we'd love to recognize you. So please take care of that. And then finally, I want to thank our sponsors. We cannot do any of this work without them. And we have a corporate roundtable, and if your organization or company is not part of our corporate roundtable, we encourage you to become a part. So first, the American Academy of Dermatology, Amgen, Acelus, Centene, and we do a lot of in-community work with Centene. It's really been exciting down in community level. We've been doing health fairs with them. DaVita, Gilead, GlaxoSmithKline, Kaiser Permanente, Susan G. Komen Foundation, Pharma, and Walgreens. These are all members of our corporate roundtable, and please give them a round of applause. And then finally, for the health policy, if you're interested in being part of the health policy, I'm going to give you Brandon Garrett's email address. So you can email Brandon. It's bgarrett, Garrett, @nnqf.org. Send them an email. Be part of the solution. This is a national movement to really try to establish health policy that will affect access for minority populations. So thank you so much. Thank you, Congressman Kelly.
Dr. Pucker, and you know Brandon knows half the people in this room already. We will now turn the conversation over to the great hands of Dr. Cameron Van Patterson, Director of Programs at the Judge Alexander Williams Jr. Center for Education, Justice, and Ethics at the University of Maryland to get the conversation underway. But let me tell you about, no, relax. Dr. Cameron Van Patterson is Director of Programs for the Judge Alexander Williams Jr. Center for Education, Justice, and Ethics, and Faculty Specialist in the Department of African American Studies at the University of Maryland, College Park. Prior to joining the University of Maryland, Dr. Patterson Served as a Director of Foundation and Government Grants at the Ellington Fund, a 501c3 nonprofit organization that works in collaboration with Duke Ellington School of the Arts from 2014 to 2017. Dr. Patterson served as the Director of Academic Affairs, Curriculum and Instruction at DESA. Dr. Patterson also previously served as National Director of the Children's Defense Fund Freedom Schools Program. Born and raised in Long Beach, California, Dr. Patterson holds a Bachelor of Arts in African American Studies and a minor in Education from the University of California, Berkeley, and holds a PhD in African and American Studies with an emphasis in the history of art and architect from Harvard University. Dr. Patterson and his wife have 2 children. Please join us, and again, thank you so much. And thanks to all of our panelists for taking the time to be here. We really appreciate it. And to you young people, all the stuff you hear today, you are our future, so hopefully some of you will be interested in the field of healthcare.
Oh, thank you so much, Congresswoman. Let's give Congresswoman Kelly and her team another round of applause this morning. We greatly appreciate your courage and your leadership. And you know, it's very important that we recognize those of us who constantly put these issues before us and keep them in the forefront of our consciousness and in the public discourse. So thank you again for creating this opportunity. This morning, I'm going to be speaking about a number of things that the Congresswoman referenced in her remarks, and I'm so glad she spoke about the Health Equity and Accountability Act, because we're going to be talking about equity and accountability in some depth in relationship to what a Truth and Reconciliation Commission is. Of course, the Congresswoman mentioned the MAMA Act, and I just have to say that we know in our communities that the health of our communities often begins with the health of women, and so that's so important. I want to thank her for that, because so often, and more often than not, women are the health providers for the rest of us, and so I just, again, want to reiterate how important it is, that legislation, that we support those efforts. So, as the Congresswoman mentioned, oh, thank you. Okay. Oh, I got the technology now, so I'm good to go. So the Congresswoman mentioned, I work with the Judge Alexander Williams Center for Education, Justice, and Ethics at the University of Maryland, and we are a relatively new policy center, and I oversee the implementation of our signature programs in these areas and strategic initiatives, and we are getting ready to launch in 2019 some programs that specifically deal with looking at mental illness and mental health. Also, we're going to be moving forward on some initiatives in the area of education. And of course, the judge's background is in criminal justice and criminal justice reform. He's done a lot of work on mandatory minimum sentencing and other issues, and currently is serving at the bequest of Governor Hogan on the commission that's investigating the Baltimore Police Department's Gun Trace Task Force. You may have heard about the corruption within the Baltimore Police Department, and so he is chairing the commission that's going to be looking into that and putting forward recommendations to ensure that we can have trust and accountability and restore civic life and public trust in our those who are charged with protecting and serving our communities. And so one of the things that becomes very clear as we delve into these issues is that there are so many interconnections and intersections in the work that we do. But today, I'm going to be speaking about the Truth and Reconciliation Commission. And so I want to take some time to contextualize what a TRC is and how Truth and Reconciliation Commissions have been used in the past, what some of the challenges are, and where we can utilize them as a framework moving forward to ensure greater equity in our communities. So it's important to understand that a TRC looks back in order to move forward. And so in many ways, they function as a bridge between past and the future, a bridge between separation and unity, and of course, a bridge between truth and reconciliation. And so in thinking about that, one of the things that we have to understand is the importance of history. And so I wanted to share words from James Baldwin, who speaks in Unnameable Objects and Unspeakable Crimes about the fact that history isn't just the past, it's something that we carry within us. We are all historical subjects. No one comes to where they are in life in a vacuum, right? There is a narrative, there is a story that we are constantly revising and telling ourselves about who we are, why we are, when we are. And so I want to establish right away the importance of history and the importance of history in the process of TRC. We have to, well, one cannot overcome what one is not willing to confront. And so we must confront our past and we must deal with the issues, the challenges that we are that produce us and that produce the world that we live in today. And so I just wanted to highlight that, and I think Baldwin does an excellent job capturing that, where he talks about how history is what we owe our frames of reference, our identities, and our aspirations. So most people are familiar with the Truth and Reconciliation Commission in the South African context, and so we're going to focus on that particular case today. I wanted to share these images just because I think they do a good job capturing the issue, what's at stake and what some of the challenges are. When the commission in South Africa was sort of announced back in '96, you can see the focus was healing our past. And then this political cartoon was very popular. You kind of see Bishop Tutu there with folks behind him, sort of press, and he's trying to figure out how he's going to get across this chasm, this schism. Truth on one side, reconciliation on the other, and you can kind of see he's holding a map, and it's like, okay, how do we make this happen? So one of the things that TRCs do is attempt to bridge these divides and establish a way forward, but there isn't always a clear path. There isn't always a clear direction. You have to create it. So a Truth and Reconciliation Commission is a body commissioned by a government for the purpose of investigating, documenting, and acknowledging past wrongs committed by state actors, in most cases. The earliest TRCs first emerged in the 1980s in Latin America with the aim of investigating the various human rights abuses that occurred under South America's military dictatorships. However, the most notable TRC was commissioned in South Africa for the purposes of investigating and documenting abuses under apartheid and legitimizing South Africa's new democratic government. That last part is very important. Okay? And I included this image here of Tutu because I wanted folks to understand the gravity and how challenging these TRCs can be. They're very gut-wrenching, they're very emotional, and they require a great level, a degree of emotional intelligence and the ability to really wrestle with yourself and look in the mirror unflinchingly. So let's just talk about some facts and functions. TRCs reside at the intersections between institutional structures and individual agency. They function to investigate patterns and events that took place over a period of time, and usually on a societal scale, to engage directly and broadly with affected populations, and to bridge social divides by facilitating reconciliation, and ultimately to foster social and emotional healing by addressing trauma and empowering survivors to share their stories in a supportive environment. So here you have an image of the Apartheid Museum in Joburg, South Africa. And I wanted to share this with you because I think it captures in really stark contrast sort of what apartheid was, what it represented. And just so we don't get too, aren't seduced by the idea that, oh, this is the past and these things are over. There are many instances happening in our country today, both here and in other parts of the world. Oftentimes people reference the conflict in Palestine, between Palestine and Israel, where TRCs are being talked about and discussed, and people are trying to figure out how to make this process work in various contexts. But I think you see here in the museum, both the country's attempt to bridge that divide and to create public spaces to support healing, and also just dealing with the reality of what apartheid meant, right, in very physical terms, and how the fundamental negation of Black South Africans that it represented. Okay, so the efficacy of a Truth and Reconciliation Commission is really dependent upon a social agreement of sorts, okay? TRCs are sanctioned and authorized by governments, state actors, international organizations, and the findings are usually officially recognized under the traditional TRC framework in order to fully investigate and arrive at the truth. Perpetrators of injustice, crimes against humanity, and other forms of wrongdoing are usually granted amnesty or immunity in exchange for full disclosure of candid confessions. Typically, a TRC has no power to charge perpetrators with crimes or provide compensation to survivors. This limitation provides the basis for the most common critique of the TRC process. Arguably, the absence of justice is an indicator of lingering political and economic inequality. Okay, so now we're getting into the issue, the heart of the matter, right? This is where the tension lies. So we think about the purpose and the public policy implications, right? Because that's what we're here to talk about in one respect. What are the long-term outcomes and implications of a TRC in this context? And so you have to think about TRCs both in terms of their intent and their limitations, right? Truth, establishing a record of past wrongdoing, so having the data to actually document what happened, right? This prevents government denials, ahistorical or revisionist histories, right? And ideally, the TRC process creates a counter-narrative, effectively reframing or shifting social discourse in a manner that empowers the voices of those who have survived trauma, the trauma of state-sanctioned violence, terrorism, and abuse. Reconciliation focuses on, even though TRCs focus on past wrongdoing, the long-term goal and ultimate purpose is prospective, meaning a future orientation. TRCs attempt to reconcile divided or polarized communities by emphasizing the importance of transparency as a means to restore public accountability, confidence, trust, and the legitimacy of government and or social institutions. Now, most people who look at our country today have commented that we live in a very polarizing time. And so there are plenty of ways in which we can think about reconciliation and the role it can play, not only racial reconciliation, but other kinds of reconciliation as well. Thinking about gender, thinking about partisanship, all of these things are relevant. And then again, thinking about the limitation, right? Reconciliations without justice, right? In the interest of a peaceful transition to a new, more equitable social contract, TRCs often forge an uncomfortable ethical compromise. Namely, they allow for the absolution of perpetrators and fail to compensate or provide alternative forms of restitution or reparation to the survivors of violence. Critics of TRCs assert that the process, in fact, compromises movements and policy efforts toward restorative social justice. However, the question then becomes, right, and remains, is there a way to integrate justice into a TRC framework? What would that look like? What is the place, if any, of justice within the TRC framework? And is there a viable, sustainable, and scalable model for social reconciliation that maintains fidelity to established principles of law, including equal justice? Or are there compelling reasons, i.e. social stability, for the TRC to remain necessarily relegated to a state of exception? This is the debate, and this is the tension that I want to put out for us to consider as we talk about these issues this morning. So I'm going to argue, in part, that equity, health equity, right, empathy and education are what allows a TRC to work, despite the fact that previous crimes are not necessarily dealt with in the court of law, okay? So a TRC framework for social innovation is one that insists upon equity, empathy, and education, right? And you can kind of see the World Health Organization defines equity as the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Okay, so we're going to return to this equity piece later. Empathy and compassion, very important, right? Being able to see a situation from someone else's point of view. And then a step further, compassion includes the desire to act on that, right? To be able to empathize with someone else's experience and then take action, right? Very important. And then lastly, thinking about the importance of education, right? In order to move forward and to allow for truth-telling of unspeakable crimes, right? And at the same time, find a way to move past it. Kofi Annan, who recently passed away, said education is a human right with immense power to transform. On its foundation rests the cornerstones of freedom, democracy, and sustainable human development. So these three things, I want to argue, are key in order to a TRC being successful. Just quickly, I want to make a distinction that I'm sure many of you are familiar with, but I think it's important, bears repeating, that equity and equality are not the same thing, right? And you see here sort of in the image a visualization of the difference between the two. Achieving equity can't be accomplished through treating everyone equally or symmetrically, right? It can only be achieved by treating everyone justly according to their circumstances. And that's sort of what the image there is showing you. Now, looking at the South African case, right, and how we bridge truth and reconciliation, what has allowed the South African example to be successful to the extent that it has is a unique characteristic of their constitution, right? One of the most progressive constitutions on the planet, and their emphasis on social and economic, or what they call positive rights, which include providing reasonable access to education, housing, and healthcare. So you have a right to these things, right? As opposed to the U.S. Constitution, right, which has a more libertarian bent to it. And so it's important to think about moving forward how we ensure equity, empathy, and education, how we ensure these rights to things like education, housing, and healthcare. Because in the absence of them, I would argue that a TRC really can't be successful, right? Because these things are what bridge the truth and allow for the reconciliation. They make the reconciliation possible. And I'll mention just one example. There's a case, it's called the Minister of Health versus Treatment Action Campaign. This was in South Africa, and it was held brought before the Constitutional Court of South Africa. And essentially, the case involved the supply of a drug called Navriapin to pregnant mothers, okay? The drug has been very successful in stopping the transmission of the HIV virus from HIV-positive mothers to their newborn children. Because the government could not challenge the undeniable efficacy of the drug, it argued that too many obstacles prevented it from safely and effectively administering the drug. The government contended that there was no use in taking a drug that possibly building up resistance to it if a mother was then going to breastfeed her child. The court responded, however, that individuals could be trained to educate expectant mothers about these risks. And finally, the government objected on the grounds of women who did not breastfeed, not having access to clean water, and the court held that this was not a reason to deny the drug, but rather a reason to supply clean water. And if no clean water was available, the mother would be advised about those risks. And so as a result, the government was ordered to supply the drug to every hospital in South Africa. In its decision, the court relied not only on the right to medical treatment, but also equality. Navriapin could not be supplied to some mothers and not others. So that's just an example of how the right to healthcare has functioned in the South African context. And I think that is what has made the TRC in South Africa successful to the extent that it's succeeding. And we know it's an ongoing process, but I think it's an important point to illustrate. So again, equity and distinguishing equity from symmetry. Here you see sort of a way of thinking about the relationship between these terms, which we oftentimes conflate and use interchangeably, but I want to make sure that we understand the distinction here. Equity really speaks to fairness, and so it implies a level of justice, okay? If you get a chance, you can look at the Atlantic Fellows for Racial Equity. They have some great opportunities that are worth looking at. So I want to sort of close by referencing comments from President Obama, who spoke at the 16th annual Nelson Mandela Lecture in July. And I thought that his comments, his speech was very profound and inspiring. And he talked about the need to reduce inequality and promote lasting economic opportunity. Talked about the fact that protesting is just simply inadequate. It's not enough. We have to make a positive argument. We have to construct something. We have to build and innovate and close the chasm of wealth and opportunity, both within countries and between them. And so I think that is what real leadership looks like. And I think that our task, our responsibility is to respond to that challenge and to embrace the legacy of leadership that Nelson Mandela has established. And I think the TRC is one way that we can do that. A quick commercial before we transition to our first panel. We are going to be hosting the inaugural Judge Alexander Williams Jr. Lecture on Ethical Leadership and Civic Engagement, November 8th at the University of Maryland. If you're interested in learning more about the center or interested in attending, please do reach out to me. My information is there. And with that, I want to transition us to this really, really engaging and dynamic series of panels that we have today. And I'm going to introduce the moderator of the first panel discussion. We're going to be looking at and thinking about the TRC on sickle cell disease. And we know that sickle cell is a disease that has a disproportionate impact on African Americans. And so as we transition to that, I want to introduce the moderator of that discussion, Dr. Latasha Lee. Dr. Lee is a senior manager of sickle cell disease and policy programs at the American Society for Hematology, where she is responsible for the day-to-day management and implementation of activities related to the American Society of Hematology's call to action on sickle cell disease, as well as the Sickle Cell Disease Coalition. She also provides input into the overall strategy of the American Society for Hematology's CSD initiative, legislative or regulatory issues related to SCD, and provides oversight for the global and research aspects of the initiative. Let's give Dr. Lee a round of applause as she comes.
So if I could have our distinguished panelists of the Truth and Reconciliation Commission on Sickle Cell Disease please approach the panel.
That'll take a while. The mic is. Yeah, it's gonna take me a while to get up there. Close. I think I'm number 4. That's 4. That's like a 1 or 2. Thank you. Oh, I really. Thanks.
So as they're being seated, in the words of the Honorable Desmond Tutu, I provide you this. Whether we like it or not, we will remain a crippled community, as long as we refuse to face our past. So with that, I evoke the spirit of the Truth and Reconciliation Commission. So welcome to the Truth and Reconciliation Commission on Sickle Cell Disease. I am so proud to have a lovely panel, including, I guess I'm going to have to order my talking points. So Dr. Mack, who's from the Ann and Robert H. Lurie Children's Hospital of Chicago. And next we have Dr. Jency Palouse from Novartis. And then we have Lydia Pecker, Assistant Professor of Pediatrics at Johns Hopkins. and Beverly Gibson Francis Gibson, President and CEO of the Sickle-Cell Disease Association of America. And then the young gentleman here, I'm so proud of him, is Mr. Lorenz Soares, and he's from the Miracle Network Children of the Year, and he's this year's awardee. And last but not least, we have his mother. So before we begin today, I want to remind you of our introductory remarks on what truth and reconciliation are. So before we begin, I want to preface this by saying that the comments, views, and opinions shared by today's panelists do not represent those of our respective employers. So we will be a bit controversial at times, and they may not align with our respective organizations. But today we are going to really focus on the past and its lasting impact on sickle cell disease, discuss the present, and then talk about actionable recommendations that we can provide to Congresswoman Robin Kelly and her staff, as well as her peers in Congress as we move into the new Congress. And looking forward and beyond, because we're in some really exciting times in sickle cell disease. So with that, if you would like to make a few introductory remarks about your experience so the audience can get to know you a bit.
Okay. Good morning. Thank you for the invitation from the Congressional Black Caucus. I'm looking forward to engaging in honest discussion about sickle cell disease. So just briefly, I did my training in pediatric hematology at Johns Hopkins and NIH, and now I'm on faculty at Northwestern and Lurie Children's Hospital of Chicago. I take care of children with sickle cell disease. My main areas of interest are doing some research on sickle cell disease and pain. I'm also interested in advocating for patients by going out into the community, recruiting African Americans to donate blood for children with sickle cell disease.
Good morning. Thank you again for the invitation. My name is Dr. Jincy Paulos. I'm the U.S. Medical Director for the Sickle Cell Disease franchise at Novartis Pharmaceuticals. So I've been in the pharmaceutical industry for more than 10 years and currently running clinical trials in the sickle cell disease franchise space.
Good morning. My name is Dr. Lydia Pecker. I'm a pediatric hematologist at Johns Hopkins, and my research interests are in young adults and adolescents with sickle cell disease, and I also study late effects of treatment, particularly on female fertility, and it's a pleasure to be with you.
Good morning. My name is Beverly Francis Gibson. I am President and CEO of the Sickle-Cell Disease Association of America. My role at the association is to ensure that we raise awareness about sickle cell disease across the country. I will also share with you that I have a family member that died from sickle cell disease, and so this is very personal for me because my own family does not believe that sickle cell disease still exists. And so I am very committed to not only raising awareness, but ensuring that there's legislation and advocacy efforts to support families and individuals living with this disease and dying from this disease every day.
Good morning. Thank you for letting me have this opportunity to speak on sickle cell.
Would you like to introduce yourself?
This is my son, Lorenz. Thank you for having us here. Thank you for the Congresswoman Kelly, Children's Healthcare Atlanta, for allowing us to come out and speak. My son, Lorenz, he is not just a sickle cell patient, but he is the face that you are not really aware of. He's the face that you're not really aware of, and I'm not sure.
We'll get you mic'd in a second. In the meantime, this year's Congressional Black Caucus Foundation's annual legislative conference, as you can see from the panel in the back, the theme is "The Dream Still Demands." So many of you may be aware that this year marks a significant time period, both for us politically as well as socially. And we remember Martin Luther King and one of his pivotal quotes about of all the injustices, healthcare disparity is paramount. So with that, we briefly touched upon a number of the issues around awareness and education, but I want to start and allow the panel to talk about the injustices that we see in terms of sickle cell disease care, as well as awareness in the United States, given the fact that many individuals with sickle cell disease typically die in their 4th decade of life. The key.
Sure, I'll go first. Yeah, it's definitely a challenge, right? Because if you Google the life expectancy of a male with sickle cell disease, you're going to find numbers like about 42, and for women, maybe 48. But that's based on old data. And so we think with patients who are followed in a comprehensive sickle cell program with sickle cell experts, that we can do much better than that, and that we can help our sickle cell patients, for all intents and purposes, die from what other Americans die from at a much older age. And so that requires practitioners to be empathic, to be advocates, to be proactive, to engage families. I think oftentimes it's assumed, but sometimes missed, that just having a trustful relationship with patients makes a big difference, so that if they recognize the practitioner who walks in the room, automatically there's a level of trust that has ratcheted up in ways that when recommendations are made, they're probably more likely to be adhered to. I don't think sickle cell practitioners have to look like patients with sickle cell disease. In other words, you don't have to have the same ethnicity in order to be a good practitioner, but I do think if we can work vigilantly to help increase the number of providers, especially on the adult hematology side, who do sickle cell disease, A, and B, who also look like the patients they care for, that will, I think, perhaps help with improving the trust. Not a requirement by all means, but I guess I would just underscore that there's a challenge on the adult side to find hematologists who are interested and enthusiastic about taking care of patients with sickle cell disease.
So earlier we had Gary talk about the zip codes and the fact that African Americans tend to reside in several zip codes. I know many of you probably know some of those, what we call disparities or deserts for hematologists, and those are for the non-sickle experts in the audience, those who typically care for individuals with sickle cell disease. They're blood doctors. And what can Congress do to really address the disparities in care? Kind of piggybacking off what you said about getting more investigators to do research, getting more clinicians to provide adult care. It seems that we're making great strides in pediatric care, and I applaud the 2 pediatric providers on the panel, but what else can we do?
So, I think we have to take the long view. So in the last 30 years, the care of children with sickle cell disease has been transformed in places like Chicago, where there's adequate access to pediatric subspecialists who can care for children. And so the things that have extended the lives of children with sickle cell disease, such that we expect all of them to live into adulthood at this point. It's good for you, Laura. Include vaccinations, penicillin prophylaxis, and a really fantastic intervention to screen children for stroke. And the ultrasound technology that lets us screen children for stroke has resulted in drastic reductions in this morbidity for children with sickle cell disease. But even for children in the United States, we know that in rural areas and areas with fewer pediatric hematologists, this routine screening is not being realized. So I think there's a first here that we need action on is making sure that the standards of care for children with sickle cell disease are not only established, because they are essentially established, but also are reaching all children with sickle cell disease. And once that happens, we know that those children are guaranteed a life into adolescence and young adulthood. And then we also know that adults with sickle cell disease are facing a true crisis in their care. There is not adequate care for these young adults and adults with sickle cell disease. And so we need Congress to act to fund centers that will care for these patients, to fund programs to train people to take care of these patients. About 10 years ago, there was a devastating hit to the sickle cell community when the NHLBI defunded the day hospitals, which were critical care centers for adults with sickle cell disease, and implementing a strategy that would bring back those kinds of centers to provide really personal and high quality care for adults with sickle cell disease is both a cost-effective way to care for these patients and also a much more humane way to care for our patients.
I would also add that access. You know, I have a young woman living in Kentucky right now. She's 37 years old. She's the only member of her family that she knows of that has sickle cell disease. And she's 5 hours away from the closest facility for care. So when she's in crisis, she's 5 hours away. And I think that we really need to look at innovations in terms of telemedicine and other ways to assist people who are in rural communities who may not be close to a facility or a hospital that could care for them.
And I agree with Beverly on that aspect as well. Even for clinical trials, we know that there's a decrease in minorities participating in clinical trials. And this is a new innovative age for sickle cell disease because we have a lot of new therapies coming out there. And so we're looking to recruit a lot of minority patients into our sickle cell trials. But one of those aspects is the barriers of access to coming to a clinical trial. So at Novartis, we've initiated a patient assistance program where we will pay for the patients to use the ground transportation that we, Novartis employees, use to get them to the clinical trials. We also provide a stipend card, a debit card. We listen to the patients. They said they don't want a gift card or anything like that. They want to be able to go to the ATM machine and pull out the money so that they can pay for the child care, aspects and everything like that. And we pay for hotel accommodations as well so that we'll be able to stop that barrier aspects and be able to provide the care that they would be able to need.
But I will tell you, we need to step back and look at historical implications of why African Americans or people of color do not participate in clinical trials. So there's a lot of mistrust. And I feel that it's important for us to state that and not overlook that because that's a big barrier and a big reason why many of the families that I'm talking to every day and encouraging them to participate in clinical trials will say, I'm not going to do that, I don't trust them, I don't want to be used as a guinea pig, and then they cite Henrietta Lacks, Tuskegee Airmen, and all those other issues. So I think it is also important that we educate, and I talked a lot about building awareness of the African American community and communities of color about why it's important for them to participate in clinical trials, because at the end of it, it's medication that then helps them and supports them living longer lives.
So that's critically important. I was literally going to use those two examples, the Tuskegee Airmen and Henrietta Lacks. And I think it goes back to trust and establishing care with providers who advocate for patients and can display empathy, right? And I think, there may be some novel ways to make sure that the best and brightest in medical schools aren't choosing career paths that are lucrative, but choosing career paths that are noble and that can literally save lives and make a difference. And if there's a way to forego or to help with loan repayment, for example, for medical school, that could go a long way so that people are not choosing career paths because of the promise of X dollars as a practitioner, but perhaps can be invested in something that hopefully they're interested in, and then on top of that, get some relief with perhaps loan repayment. I think that's critically important. And just to piggyback on the importance of getting patients enrolled in clinical trials, right? There was only one FDA-approved drug for sickle cell disease for years and years and years, and that was hydroxyurea. And the short version is that hydroxyurea can increase fetal hemoglobin expression. It may do other things as well, which may mitigate some of the complications of sickle cell disease. And we've all seen it. There are patients who literally have not heard of hydroxyurea, don't know what it does. And this is a medicine that can simply be prescribed. Patients need close follow-up, probably under the care of a hematologist. And those patients, in theory, can have preservation of their kidneys and lungs that allow them to live through adolescence and into young adulthood, and hopefully be transitioned to adult providers. So I think getting patients enrolled on studies is critically important. I think sickle cell disease is probably lagging behind, and so if there are ways for the NIH to improve and increase the budget to support sickle cell research, that would be critically important. Furthermore, we don't even know how many patients with sickle cell disease there are in this country, and that is a tremendous lapse, because if we don't know what the problem is, then that makes it a little bit harder to figure out how we can solve it.
With that, let's actually talk to the expert in the room, the RINs. You're an individual living with sickle cell disease. What has been your experience in getting care? What are some of the complications you face with your disease? Let the audience know what you experience on a day-to-day.
So, first, sickle cell, you have a pain crisis when you're cold. So most of my hospital stays are during the winter. And when I go to the hospital, Children's Healthcare Atlanta is real, nice to me. And, my complications are only during the winter. So.
Do you feel like you get adequate service when you're at Children's Healthcare Atlanta?
Yes.
Does this prevent you from doing daily activities?
Yeah. Only during the winter, though.
Only during the winter.
Yeah.
Do you think other children receive the same kind of care that you receive? Children that don't go to Children's Healthcare Atlanta?
No.
Why?
Because Children's Healthcare Atlanta does an extra step for you every day, and they treat you very good.
So, Lorenz, do you trust your provider?
Yes.
You do? That's important. I've heard trust, and we're talking about truth. But I do want to challenge the audience, and I want to challenge the panelists. Everyone always remembers Tuskegee and now Henrietta Lacks. And there's a recent study in 2018 by Research America that indicated during an oversampling of minority populations that trust is no longer a barrier for clinical trial participation in the African American community. What is implicit bias. The fact that many times clinicians are not actually asking people of color to participate in clinical trials. Do you guys care to comment? Lorenz, have you ever been asked to participate in a clinical trial?
Are you sure?
Wasn't it when we had that thing?
Yes.
Yes.
Yes. I want to say Lorenz has been asked quite often, and I am leery, to be quite honest. I am leery. I know that it's needed. Research is absolutely needed. I need this to be resolved in this lifetime, not the next lifetime. But with that being said, as a mom and knowing my history of African American woman, I am leery. I encourage Lorenz to be proactive in his own good health. I do look forward to him progressing in life. He is going to progress in life. He's going to move forward to do great things, and that is, research is needed, but I have to be honest, when I sit back and I think about it, I let go of my fears and I allow him to be involved in this, because without this, we can't look forward to a remedy. We can't look forward to easing his pain and the pain of other children like him. Now, Lorenz receives excellent care at Children's Healthcare Atlanta, and I'm sure there are other facilities around the world, but I also understand that right in Georgia where we live, there are children who don't get treatment, children who don't get follow-up, children who are not provided these medications that are daily, that they need daily to be proactive in their own good health. The crisis is not just when you're in crisis. The truth is that you're trying to prevent a crisis, you're trying to monitor this crisis. There were times when I felt like I was always in crisis mode. I learned that we can move past this pain, and that if today's a good day, we're going to go hard today, because tomorrow, we don't know what tomorrow will bring. But I want to say that these clinical trials are necessary, and they are scary for parents of children with sickle cell. I can't speak for anybody else, because I'm African American, because I can only speak my truth, which is I am very leery, but I do let go of my fear, and I trust Children's Healthcare Atlanta. It's our second home. I trust them
without a doubt. And I'm hoping that the medical community, that is these kind of follow-ups and being involved in not just my child's life, but children like Lavonne's, that this is mandatory. And it's, I heard you say that you want children, you want doctors to, up-and-coming doctors to not just chase what's going to be lucrative, but to be committed, and that's what we need. That's really what we need, and that's what I feel like I have, and I would love for other parents to have the same trust in their physicians and their medical facilities, and I don't know that they're getting it. I don't think that they are.
I also wanted to introduce the fact that we have an opioid epidemic in this country that's also impacting people living with sickle cell disease. I have an employee who has sickle cell disease. She was hospitalized 4 weeks ago, and she told the physician that she needed medication for pain, and he refused. And I'm hearing that story more and more across this country, so I don't know if anyone on the panel has heard this, but I think it's also another issue that we need to look at as a country.
Yeah, so I participated in a symposium at Northwestern that was tackling the opioid epidemic in Illinois. And there were a lot of stakeholders present, representatives from the state, practitioners, researchers, physicians, lawyers, etc. And I was wearing my hematology hat because I think in an era where patients who have sickle cell disease, and some would argue calling them vaso-occlusive episodes instead of crisis, even though I grew up, learned to use the term vaso-occlusive crisis, kind of has a connotation, and if you maybe swap out the C with an E, you consider it an episode, that makes it more manageable. It doesn't take away the pain, but maybe gives us a different viewpoint. And the bottom line is that the opioid epidemic and access to opioids for patients that need them are not the same. And I think the truth is that opioids are being overprescribed for dental procedures, orthopedic procedures with poor follow-up, and patients end up getting addicted, but cancer patients included, and sickle cell patients who have not only acute pain, but chronic pain, and sometimes acute on chronic pain. That's very different than I came in for a surgery and had pain and I need opioids for a short period of time. And so now we've introduced another barrier, right? Because when sickle cell patients are not believed when they have pain, or they go into the emergency room and they get viewed as being drug seeking, now they finally get their pain medicine in an ED, and they go home with a limited supply of opioids, and if they need more, you can't call in the opioid prescription. So now they need to go back. So now we're asking them to go back to the ED and endure the same scenario that they endured the first time, or get plugged into clinic, and there may not be clinic appointments for a few weeks. So it just adds another barrier, and so
When you talk about the cost associated with sickle cell disease, because we know that they're quote-unquote called frequent flyers, but part of it is due to our healthcare infrastructure in the U.S. And the fact that we're putting these barriers and limitations. Lorenz, have you and your mother faced any challenges in terms of ever obtaining the medications you actually need in an appropriate time?
Yes. One time during I think it was late September, there was a hurricane and the air pressure started changing, and then I got a pain crisis and the power was off for 5 hours. Then the next day when I started feeling better, I still needed medication. We went to 2 different Krogers and they wouldn't let me get medicine.
But we always see that when opioid prescribing comes out, the new regulations by CDC and HHS, that cancer always gets the carve out. Why is there the disparity for sickle cell disease?
We have a long history of people not believing our patients, and I think that the fundamental disparity is about whether you believe the person in front of you when you meet them. And to tie this back to different models of care for taking care of patients with sickle cell, so I mentioned the day hospital model before. So day hospitals were hospitals and small infusion centers that were open somewhere between 8 a.m. and 6 p.m., something like that, and they saved seats for patients with sickle cell who could call and say, I'm having a pain crisis, I need to come in. And they were met with in the day hospitals, and there are some centers that still have day hospitals. Dr. Sophie Lawrence-Cron at Hopkins runs one of these for our adult population. For those patients, they are invited to join a community of caregivers who are familiar with the disease, and they're familiar with the doses of opioids that are required to treat the patients. And so they are getting the appropriate doses of medicines to treat their pain in a timely manner. And what we've seen in Baltimore is that model of care actually not just reduces ED use by sickle cell patients at our center, but it has actually reduced ED use all around the region, which is remarkable because it's a much less expensive way to give care, and it's also a much more comfortable way for our patients to receive care, because they're being cared for by people who not only believe them, but also know their histories and know what is required to make them comfortable. And it is a drastically different face of this disease for people who can experience care in that way.
And it'd be remiss of me not to acknowledge my colleague in the audience, Star Webb with the American Society of Hematology. The Society is working on new clinical practice guidelines for the acute and chronic management of sickle cell disease, and she'll be available later to talk about our guidelines and our current public comment period. But with guidelines, when you talk about opioid prescribing, we know that NHLBI in 2014 had expert panel recommendations, but why aren't they being implemented? Why are we seeing barriers to access of both drugs as well as clinicians who are actually following those recommendations and guidelines?
We think sickle cell is very unique, but in this way, I don't think sickle cell is so unique. The time to follow guidelines is extremely delayed in medicine, and that's true across many disorders. I think this is no different, and comes back to the issues around many misgivings that people have about prescribing opioids, many misunderstandings about sickle cell pain. I think that's probably the primary barrier to implementing this guideline. Another issue is whether you're aware of that the guidelines exist. So, some people go around their hospitals installing the guidelines on every computer in the hospital so that people have access to them. But if you're not even aware that they exist, you're not going to follow the rules.
Exactly. I think in the sickle cell disease expert centers, people are aware of it, right? But for those places that don't have a sickle cell center, what are they going to do? They're not hematologists, they're family practitioners, pediatricians, just, doctors that don't have that experience. And textbooks, when we were in medical school, we get a page on sickle cell disease, and so it goes to that aspects of education is key and fundamental for this disease, that we have to start educating our new healthcare professionals and even the ones that are still in practice, about the new therapies that are available and how we're supposed to treat these patients. And then, I don't know if a lot of people realize that sickle cell patients start having a crisis at 6 months of age. Now, and I know a lot of institutions that give pain medications to babies 6 months of age. Can you imagine then what the tolerance level of that patient is going to be when they're an adult or when they're a teenager? It's not going to be that same tolerance level as you and me who are going in for a regular surgical procedure or tooth extraction. It's not. And I don't think that education aspects of people realize that it's not because of that patient's fault. It's because that's all we had to give patients at 6 months of age. There's hydroxyurea, yes, but it wasn't approved back then for those babies. So what do we do? How can you, being a mother myself, just to see my, a 6-month baby crying, that's painful, and we would do anything we need to help them. And so I think that's just something that we created, but people do not understand. Other healthcare professionals do not understand, so.
I think another important point, which ties back to your research question, is that opioids are a really inadequate therapy for sickle cell disease, and our patients deserve better than opiate medications. Yes. They are not specific medications for sickle cell disease. They do not address the root causes of the disease. And there are any number of drugs that are in phase 1, 2, and 3 trials. And it is actually a very hopeful time for sickle cell, probably more hopeful than any time we've seen since sickle cell was first discovered or recognized in 1910 in this country, in Chicago. Yeah. And so, one of the goals in introducing our patients to research, inviting our patients to help us find out what are the next best treatments, is that we hope that those will be opioid-sparing therapies, that we can actually stop using these medications. These medications have bad side effects, and we know that, and the patients know that. It's not a secret. And so we really owe them a better therapy than opioids for pain.
I agree with that. So I did a little bit of research on this very topic. And so what we're learning is that patients can have very different types of pain, and they can have pain that is not the same in both locations. So, or in multiple locations. So a lot of times we'll see a patient and say, well, what's your pain score, with 10 being the worst? And they'll say it's a 10. But they have pain in the right knee, their left pinky toe, and their right shoulder. Well, is it a 10 in all of those places, or is it a 10 in just one place? Furthermore, if I open that back door and slam my finger in the door, I'll have a certain type of pain, but I can also have something called neuropathic pain, which is chronic nerve damage, which is treated with an entirely different subset of medications. The last point I'll make is, in oncology and in other diseases, they're doing things that are called precision medicine. And so it's entirely possible that with opioids, which is a medication like other medications, those medications are metabolized by proteins that you inherit from your parents. So Jinsey may have genes that cause her to metabolize opioids more quickly, and so she needs more medication because of her genetic makeup, not because she's drug seeking. And Lawrence may be on the same dose, and he may be susceptible to over-sedation from the medication, not because he's being overdosed by the practitioner, but because his genetic makeup has afforded him being a slow metabolizer, so the drug sticks around a lot longer. So there are these nuances, there are aspects of precision medicine that are being applied in other diseases, which hopefully will be applied in sickle cell disease as well, so we can appreciate some of the nuances and more adequately treat their pain.
I'm going to make a somewhat selfish plug for a federal program that recently announced yesterday, a new initiative. So the National Heart, Lung, and Blood Institute announced yesterday their Cure Sickle Cell initiative.
Yes.
And this is really focused on providing a cure within the next 5 to 10 years for sickle cell disease. And with that, it's really important to note that they're also doing programs around the omics. So we're talking about genomics, proteomics, metabolomics. So the research that they're doing is important, and we must continue to advocate for a continued investment to the NIH and the respective institutes. So pivoting a bit, we talked a bit about pain, but we know that sickle cell disease is a complex pathophysiological disease affecting literally the entire body. But a lot of attention is focused on pain. We know that a lot of medications, and even those that in clinical trials, really focus on vaso-occlusive crisis. What can we do to really challenge, the landscape? Helping to develop multimodal therapeutics, looking at both macro and microeconomics, because we know that this population is largely publicly insured. I really want you to think of this in the lens of social justice. There was a congressman, I believe, Congressman Bill Foster, who says he's committed to sickle cell disease because he sees it as a continuation of some of his social justice issues. What needs to be done, what can be done, and feel free to be controversial.
Well, one of the things that we've been talking about in Maryland is the fact that for patients who are on Medicaid, Medicare, if they have a crisis within a 30-day period, they cannot get service and get that paid for through Medicaid, Medicare. So that is something that we're also talking about for patients. And that's state by state it varies in terms of those policies. But that is definitely something that's also on the table in terms of patients who may have a crisis, within a 30-day period, back to back.
A justice perspective about sickle cell disease requires that we recognize that at the federal level, about 10 years ago, the federal government was outspending sickle cell research with CF research 8-to-1. So for every $8 federal dollars spent on cystic fibrosis, which is a terrible disease and deserves research, there was $1 being spent on sickle cell disease research, and that has to change. Yes. And that has to change so that we can develop important therapies therapies to reach our patients. So there are cures for sickle cell. We need ways to be more creative to let those cures reach more patients. We need different cures, and that's going to take money. The other thing that's going to take money is actually providing the appropriate care for children and adults with sickle cell disease and their families. And we know that the systems of care, really, we say in our clinic, it takes a village to raise a sickle cell patient, and that's because we need social workers, psychologists, community health workers, and doctors who work in teams with nonprofit organizations, and we work with schools, we work with job centers, to make sure that our patients can have full lives. It's not enough to keep our patients alive. They really need to be able to have a full life, and that's going to take a lot more money than has been invested in the problem yet, and a real acknowledgement of the depth of services that people with sickle cell need. For every organ that can be damaged by sickle cell disease, you sometimes need a specialist, right? So you could need a neurologist, a pulmonologist, a nephrologist, an ophthalmologist, sorry, skip the eyes, right? Yes. Ophthalmologist, an orthopedic surgeon, and many of our patients need all of those doctors. And many of them have health insurance that limits their access to those doctors, or they don't have access to specialists who have experience dealing with sickle cell complications. And so this is a ripe area for investment.
I would also add the mental health aspect.
Yes.
Because many people don't realize that people living with sickle cell disease are also dealing with, depression and anxiety, hopelessness. Stigma is also a big issue.
Yes.
And the mental health community needs to also be a part of this conversation. Yes. I would also add that sickle cell trait screening is another big area where, it's a preventative measure that a lot of young people, and I say young people because many of us, when you're dating, you're not thinking about having a disease that could implicate and impact your life forever if you have children. But sickle cell trait screening is another big area that I'm not hearing a lot about, and that we need to really, really push for younger people.
Beverly, that was awesome. Last week, Beverly's organization and my organization did a briefing on Capitol Hill on sickle cell trait.
Yes.
Did you know that New Hampshire,
Yes.
was the last state to start newborn screening for sickle cell disease in 2006? That means there's a generation of people who don't know their sickle cell trait status.
Millions. Yes.
And so I think it's all about awareness, and I think education. So I'm going to pivot this to Jency because I know we're going to be closing out soon, and she has a very awesome technology that I hope Lorenz will take advantage of. And it really is about education. So I encourage you, if you're all interested, to check this new opportunity out.
So in this disease state, we've noticed amongst, as I mentioned before, amongst healthcare professionals, there's a lack of knowledge about sickle cell disease, and amongst the patients. So to increase the education about that, it's not just a pain crisis, it's not just about the VOC. Every VOC matters because it can lead to end organ damage, right? And so at Novartis, we've created a virtual reality tool, okay? So it's a distinctive and an effective tool because it inspires learning. We're hoping that it helps patients engage with their physicians to continue talking about their disease state because they become more knowledgeable about that. And hopefully with that, will also increase the continuum of care, because if they know what's going on in their bodies, that they know that end organ damage is happening, it's just not a pain crisis, then they'll take actions to help and find a provider. They're just not going to stay at home and be like, okay, well, I can hold it out for a few more hours or something like that. So we've created the virtual reality tool, and it is with us. So if you are interested in trying it out, please come and see me afterwards, and I'll be more than willing to give you a tour.
Yeah, I've done it, and it's pretty cool.
So we often talk about the face of sickle cell disease, and I'm so proud to see Lorenz here. But Lorenz, have you encountered people who don't look like you who have sickle cell disease?
Yeah, a couple of people I can't.
And describe what those people look like, because I think people always label this a black disease because remember in the 1970s it was the Black Panthers who really brought this forward to get us where we are with sickle cell disease in terms of legislation, in terms of awareness. But then what happened? The ball got dropped, right? So who do you typically see who don't look like you who have your disease?
Because I met a good friend at camp. It was like Camp New Hope. It was, I think it was 2016, I went, and I met him, and we talked about it. He had sickle cell. Yeah,
Was his ethnicity different from yours? What was it?
Indian.
He was Indian.
Indian, right? So, for those of you not familiar with sickle cell disease, it actually is an evolutionary adaptation, that we kind of adapted and got as a result of malaria. So in malaria endemic regions of the world is where you find sickle cell trait. However, when you get two individuals with sickle cell trait or sickle cell and thalassemia or sickle cell and a number of other mutations, you can actually get sickle cell disease. And it's a very complex and heterogeneous disease because it's not just SS, it can be SC, it can be S beta thal, and numerous others which we won't get into today. So when we talk about bias, we talk about sickle cell is not just black. Let's be honest, it's Indian, it's Hispanic, it's people from the Mediterranean, so they'll look white with blonde hair and blue eyes. Mm-hmm. But they get labeled a lot by saying they're drug seeking when they seek care. You don't have that disease, you must be confused. They too have sickle cell disease. So I know I have only a few minutes, so I want to offer the panelists one thing that they would bring in terms of truth and how you would reconcile it, so that Congresswoman Robin Kelly and her colleagues in the CDC can really do some actionable things in the next Congress.
Well, there's Senate Bill 2465 pending, and many of our colleagues have been talking about the Senate bill because initially it was a sickle cell bill, and from my understanding, it's now been broadened to include other rare diseases. And so the sickle cell community is questioning whether or not they're going to get left off the table again because of the expansion of that bill. So that's currently happening now, and there are conversations around the country about that.
I'll provide one clarifying statement. So having advocated for this with Senator Booker and his staff, and Kim was recently honored for her advocacy in this regards, the only problem with the Senate oftentimes is that Senator Alexander is very leery of disease-specific bills. However, it is the intent of HELP as well as the intent of the co-sponsors to remain it to have sickle cell disease in it. If you go to the language in the public health law, it still lists sickle cell disease and it's codified in that way. It's just in order to pass out of committee, it must stay broad. But not many people necessarily read back into the public health law to actually see what the changes are. So this is really getting sickle cell disease continued because we have not had authorization or appropriation since 2009.
I guess my thinking is more macro and not maybe completely specific, but I think getting sickle cell patients access to care, curing their disease is the right thing to do. So given that it's the right thing to do, we need to be as proactive as we can to make sure patients get the care they need, that we fund acute care facilities, hospitalizations, so that moms and dads don't miss work, kids don't miss school, they get the therapy they need, and they go right back to school the next day instead of being in the hospital for weeks on end. And I think getting people to acknowledge that, you know, when you're in high school and in college, you have a decision to make. And you can go make the big bucks, or you can take care of people who need help. And I think, you know, I'd like to encourage my kids and other kids to make a decision about just doing the right thing. There's a need. If that need is not filled, these patients potentially are going to continue to be behind the 8 ball. They're not going to have as many advocates, and then we have to deal with not having adequate numbers of providers, but then in addition to that, implicit bias, as you alluded to, where patients don't hear about therapies that are available to them. So I think it's incumbent upon us all to, you know, walk out of our silos, talk to people who don't know about sickle cell disease, call our congressional leaders who don't have sickle cell disease in the front lines and say, this is something we need to think about and talk about and why. And it could, some of these options may actually help us save money. And so that would be sort of my global pitch.
I would ask the patients to speak up. If no one knows about it, no one's going to do anything about it. I can only talk about the Indian community, but I think it's similar to the African American community, where we tend to hide things in. We don't like to talk about what's going on in our lives or what's going on with our families and everything like that. But if we don't let people know what sickle cell disease is and that you have it and that what it's doing to you, there's not going to be any help and awareness out there. So patients, I would ask, please speak up, let people know, and be your own advocate. You're your own powerful advocate. Your story is unique, and it's very powerful, and it's very moving. So I think you can do a lot with your own voice.
I'd like to ask our representatives to both raise the floor and raise the ceiling for sickle cell disease. And so what I mean by that is that we know that there are a set of both public health and individual health interventions that are essential and transformative for patients with sickle cell disease, and we need care systems that make sure that all patients with sickle cell disease get that. So raising the floor says that we know what we can do right now to make life better for patients with sickle cell disease, and we need to do it and make sure that all patients have it. Raising the ceiling says that we know that there's also new biomedical research that's creating new standards for how we can treat sickle cell, and we need to keep pushing that ball uphill as aggressively as we can, because it's really time to cure sickle cell disease, not just here, but also in sub-Saharan Africa, in the Dominican Republic, in Haiti. And so doing everything we can to push those trials forward, to recognize that the participants in those trials are heroes who are taking a significant risk for themselves or for their children, and to really honor their place in that research. But I think there is a major role for Congress to play in putting the spending in place to develop infrastructure on both raising the floor and raising the ceiling for this disease.
Domestically and abroad, and so I am proud to be part of the American Society of Hematology as we embark upon a new initiative in sub-Saharan Africa. And I'd like to thank Novartis. There's a film that, if you would like, I can send you the link to, that really highlights the burden of sickle cell disease in Africa, where most babies won't see their 5th birthday. They die of sickle cell disease, and that's just not acceptable. So I want to let the expert on the panel close. What is your dream, Lorenz, for sickle cell disease?
That there will be more awareness in the next 5 years, and more cures, and better ways to treat the pain.
Thank you.
Let's give the panel or the speakers on this commission another round of applause for their courage and bravery in speaking with us this morning. We're going to transition here. In the interest of time, we're going to move rather quickly to our next commission discussion. And so I would ask that folks, if you need to step out and use the restroom, please don't go too far, because we are going to so stay on time here. Discussion, which will be looking at HIV and AIDS in 2 minutes. 2 minutes, so please get your water and step to the bathroom and come back. When you come back in, please come to the front so that we can have a more intimate conversation about HIV and AIDS. Again, in the interest of time, we're going to keep things moving as expeditiously as possible, and so I want to invite you to take your seats at this time and settle in. Yes, the members of the next commission are invited to take the stage, take their seats here. We are delighted to have with us a filmmaker, Mr. Nathan Hare Williams. And we're getting ready to screen a short film that he's produced, a critically acclaimed film that looks at HIV and AIDS and sort of where we are. Some recall that Nelson Mandela spoke about AIDS as a pandemic years ago. And we don't hear as much about it now, but this film really casts a spotlight on where the conversation, where the health equity conversation is with respect to HIV and AIDS. And so we're going to queue up this film, which again has received critical acclaim, won several awards, Sundance, Cannes, both on the continent in African film festivals and domestically. And the film is currently traveling nationally. And so you are going to get a chance to see this film. And we're going to have some discussion about it and about the issues it raises for our next commission, which looks at HIV and AIDS. Right? Gonna get the lights, please.
Enough of that.
Wow, that's all I can say. My God. We're now going to hear from the HIV AIDS panel, and I'd like each one of you to introduce yourself. It's for a minute, but I will say that was spectacular.
I'm Nathan Hill Williams. I am a writer, director, filmmaker, and lawyer. I went to law school here, actually, at GW, and I'm just really happy to be here. Thank you so much.
Thank you.
Hi everyone, my name is Latasha Khan. I'm part of the patient care and advocacy team at Walgreens, and we're very happy that we were invited and able to participate in the conversation.
Gabriel Novenado, I'm the Chief Executive Officer of True Evolution, based in Southern California, and I'm also a former member of the President's Advisory Council on HIV and AIDS.
My name is Tony Crystal Walker. I'm the Director of Provincial Community Partnerships for AIDS Alabama in Birmingham. I am a man, I'm Black, I'm a dad, I'm an uncle, I'm a brother. I'm unapologetically Black and gay, and I've been living with HIV for over 20 years.
Oh, sure.
All right. I'm Douglas Brooks, Senior Director for Community Engagement at Gilead Sciences.
Thank you so much, and my colleague Terry Sewell will be joining us. She better join us. With Alabama folks. She's coming. She had her own panel before this. I wanted to start, since we just saw the film, with the film. Why do you think film entertainment is an effective means to talk about AIDS, and why did you choose to make the film?
I've said this many, many times. Aristotle said something like, you don't change people's minds through intellect, you do it through emotion. The thing that sums up kind of the impact that a film can have is there's two examples. One is the first church that we ever showed the film at in Cleveland, in Lonnie Temple, the first lady of the church, who I presumed was in her late 40s, came up to me and said it was the first time that HIV and AIDS had been humanized for her. And that stuck with me because that was the point. And then there's a lot of, if you know anything about the virus and where we are with the medicine, there's a lot of information in the film that, like Mary Poppins is putting full of sugar and helps the medicine go down. Most people in our community still have never even heard of PrEP. And what that is, and Jessica brings that up, and audiences that have heard of PrEP, I would say about 95% of them, I mean, not people outside of the field, they heard about it from How to Get Away with Murder.
Yeah.
Wow.
And so film and television have a way of impacting people emotionally so that they carry the information with them, and we're a community of griots. We come from a history of storytelling, and you can read a pamphlet, you can see a PSA. There's nothing like the emotional impact. People usually get mad at me because the end the way it ends. There's nothing like the emotional impact that film and television can have.
Now, how widely has this been shown?
Oh, wow. We debuted in February 2017 at the NAACP Image Awards. And since then, we have been now to 42 major festivals across top festivals across the world. Amsterdam, Cannes, we won an African Oscar. And then community screenings sponsored by AIDS Healthcare Foundation and Gilead. And so I would say at least thousands and thousands of people have seen it, and now we have a new partnership with the National Organization of Black County Officials. So we're taking it, that's Dr. Helen Holton and her organization are responsible for us being here, because now it's time to take it to elected officials and use the film to try to change some policy.
To one of the county officials, so we can go back to Illinois. How many people in the audience have seen this before? That's what I was asking.
Yes.
This is a whole new audience.
And we want to keep doing that. That was my goal. Is I wanted as many people to see it as possible. I'm from Illinois, I'm from Chicago, and we still have so many more audiences for it to be seen.
I do a lot of work around diversity, and we all in race relations, and we always say that stories are what changes hearts, not necessarily all the statistics. So, Tony, I want to go to you because you have a story, and would you like to share your story with the audience and where you are now, and all that good stuff?
Yeah, so again, my name is Tony. I'm from Birmingham, born and raised in a little town called Dolomite, but that means it really exists. I'm 51 and a half, as the kids say, and for almost half of my life I've been living with HIV. I was diagnosed when HIV was killing people. I had many friends who died. When I got my diagnosis, I myself prepared to die. At that time, there were some medicines that weren't that great. And at my age, I was like, you know what? There's no reason for people to die 4 months after they find out they have a disease. Because just merely knowing that you have a disease doesn't mean you're going to die from it. So I surmised it may have been meds. So I chose not to go on the meds. So I lived about maybe 8 years before I got mature. By that time, they came out with the ARVs. That movie was awesome. When you think about HIV stigma, that was my story, but that story got me to where I am. I had the exact same thing happen to me with this guy, and our story I married somebody else, but that scenario prepared me into leading with my status, because like with her, she was afraid of being hurt. I realized that no one can hurt me. People don't only do to you what you allow them to do. So at that point, I decided, you know what? I'm not going to put myself through this. Forget them. I'm not going to put myself through it. And it was just very heartfelt and a great story on that. But HIV has been part of my life for a while. And in 2014, I was diagnosed with colon cancer. And really about that too. When people hear you have cancer, you get, when you hear HIV, you deserve that. That means it's something important to me, because with HIV, people think that you have to sleep it out. We sexualize the disease. Yes. Women live at the intersection of a lot of different things: poverty, poor access to health care, education, and it's transmitted primarily by sex, but it's not really a sexual disease. And I think you can pin that narrative on it. Cancer did a number on my body. I live with a permanent ostomy. And right now, if I were perfectly healthy and you told me that I would have a choice between cancer and HIV, I'd take the HIV. I take 1 pill a day and I'm fine. The problem with cancer is it will kill you. I woke up a lot of times thinking, has my cancer come back? Don't let me have a real pain or something. They're like, oh my God, this is bad. I never worry about my HIV. I also credit my HIV for helping me find my cancer. A lot of men in particular, we are horrible when it comes to healthcare. We go to the doctor when something's about to fall off, otherwise it's ibuprofen or. But because living with HIV for as long as I have, it caused me to engage differently with medicine. It made me become a better advocate for myself. So when they kept telling me, well, we think it's this, and this, like, well, you've been telling me that for 9 months. We need to try something else. So I was able to catch it early. I'm 4.5 years cancer-free, and undetectable.
And Douglas, can you talk about the stigma that people face and then they don't want to go to treatment or we can't keep them in?
Yeah, so I sat in on the previous panel, and I wrote some words, stigma, mental health, clinical trials, fear of clinical trials, real issues, telehealth, no awareness of treatment and prevention. That was all in the context of sickle cell. All of this applies right to this subject in this context as well. And I too better want to just say how amazing that film is. And we did have the opportunity to sponsor the premiere of it. And somebody, I don't remember who, sent us a clip. And it stayed in my inbox for a couple of days. And at some point I thought, oh, well, I'm going to take a look at this. And I thought, oh, we have to do this. We have to support this. Because you're exactly right. All the issues come up in this film, and I think it's particularly important. I too am a person living with HIV for a very long time, Black gay man, but in audiences like this and across our country, where we have such lack of awareness among Black women who are 11 times, I think, more likely to have HIV than white women. Black trans women, Black gay men, for sure, and I think there's more of a conversation. We have to have it in a holistic manner, a comprehensive manner about our community at large. And truly, the previous panel, there are things you know that we just sort of forget. And so thank you to you for leading the conversation about our health and health equity. And I think the more we can contextualize it in that space and in the truth, and I love the truth and reconciliation framework of discussing, we had a past where the disease was so labeled as a gay disease and so sexualized and stigmatized. And if we think about putting it in the framework of just keeping our people well and healthy and preventing illness and disease where we can and treating it in those places where it exists, I think we have a greater opportunity.
And Tony, can you bring in the issue around Gabriel, Black and brown and homelessness in our youth?
Sure. Well, first, I just want to say to Nathan, wow, brother. Nathan is one of my closest friends, and it's interesting. We know each other's craft. I know he's a filmmaker, but then when you actually see one of your best friends film, you're like, you're a filmmaker, bro. You really do stuff. He's one of my best friends. So excellent work. You represented us well.
I have to say, you remind me of my best friend's comment, and she said, right, you're in Congress? I cannot believe that.
But I'm very clear that if America has a cold, Black America has pneumonia. But if Black America has pneumonia, then Black queer people are on life support. Mm-hmm. And the reality is that homophobia is one of the most unaddressed social determinants of health that are plaguing Black and brown people in HIV in America today. And that's because, as a person living with HIV as well, I am more than just my biology.
Yeah.
I am also a psychosocial, spiritual human being. And when I step into the world, I'm stepping into the world in that sense of complication. And in order for me to access healthcare services, to generate the self-efficacy, to overcome barriers to care, to summon the strength and courage to take a medication every day for someone who is positive and now for those who are negative, that is a sense of trust that you have to have with oneself. Mm-hmm. And one cannot have that trust if one is afraid of their own reflection. And we are afraid of our own reflection because people who look like us tell us that we are unworthy. And people who look like us, who are supposed to be vanguards of the village, are some of the greatest thieves against our own sense of self-identity. And so until we can have a conversation that we as Black people come from a myriad of lived experiences and a myriad set of identities, and that's going to inform different sets of behavioral choices. Until we can have that kind of an honest conversation, it does not matter what kind of interventions are put in place. It does not matter what kind of barriers to care we overcome. It doesn't matter what kind of federal policies you write or state policies you implement. It doesn't matter how many amazing companies are stepping up to give us the resources to do the work. But if the individuals that need the help don't believe they are worthy of it, But I want to also end that story with saying that homophobia has done something magical. It gave someone like me an opportunity to transcend. And when Black and brown queer people can transcend the homophobia that is imposed upon them in community, when we can move past that, there is a resiliency of magic that happens. And then you have things like Pose FX. You have things like Toby Garcon and Leonie Maldonado. You have the Daniel Driffins and the Darwin Thompsons and the Marvell Terrys and, the Valerie Spencers. You have all the amazing people and the Trina Scotts in the audience. You have all of the amazing activists because we transcended. So I also am grateful for homophobia for giving us a weapon to know our better selves.
And you remind me of something I've heard so much since this conference has started. Know your power.
Sure.
And also exercise that power. I can choose on This is my incredible, wonderful colleague, Terry Sewell from Alabama. I apologize for being late. My panel just ended. And I want to thank Robert Kelly for her leadership on the Health Braintrust. I had a question, but I want to bring these in just to have the opportunity. And thank you, Walgreens. I always show I take my high blood pressure pills from being in Congress. I take my high blood pressure pills from being in Congress. Neither one of us used to take them. So my Walgreens ladies. But can you share what Walgreens, how you're interacting with the AIDS community and what you're doing?
Yep, so Walgreens, we're everywhere. We're really there where it counts. We have 8,000 stores, 1,000 of them are HIV specialized. So the pharmacy team, the healthcare professionals in those stores, even the store team members, we've trained them to be culturally competent, to be aware of the stigma that exists. Listen, you can walk into Walgreens for your groceries, you can walk into Walgreens for a flu shot, but then you can also walk into Walgreens for counseling and support and adherence and even HIV testing. Right. So we're there where it counts. We're really there. We show up. A lot of our stores, a lot of our stores offer testing on National HIV Testing Day. We're there to confront the stigma that unfortunately still surrounds the disease. We have services that are there to support people who are on HIV treatment, but then are also on PrEP.
I wanted to ask, the reason why I'm so excited about participating, not just because Tony from Alabama is also a panelist, is because there's such a big rise in HIV/AIDS in the South in particular. And Tony, I was wondering if you could talk a little bit about AIDS Alabama and your work there, and why do you think that the incidence is so prevalent in the South still, as well as the fact that among Black women there's a big rise? Can you talk a little bit about why you think the prevalence is so much higher in the South, and specifically about what AIDS Alabama is doing to address that?
So the main thing, again, is the fact that HIV is not necessarily a sexual disease. So when you look at a map of the United States and all of the disparities that we have, we look at health equity, you look at education attainment, incarceration. If you were to run all of the states that have high incidence of that, they reflect the Deep South, which is pretty much North and South Carolina, Georgia, Tennessee, Alabama, Louisiana, Texas. But we leave out institutionalized racism, because if you put up a map of the slave states, it's the exact same states. The exact same states. So in my earlier session, they were talking about history. So we have a lot of historical trauma that exists in our community that no one really wants to talk about. Racism is over We had a black president, and it's not. So when you look at those issues, we also live in the buckle of the Bible Belt. So there's not a lot of conversations about HIV held with the one place that is African Americans we've always found solace. The Black church has been at the forefront of every issue that's affected us, from slavery to civil rights. But when you mention HIV, all of a sudden we get quiet. So when you combine all of those things, and the rampant poverty that exists, it's a breeding ground for any type of disease, not just HIV. But HIV is a real big issue for us. As it pertains to women in HIV, a lot of times, and I'm also glad that you didn't vilify the quote-unquote download brother in there. Because, there are some men who are not careful and will transmit to women, but a lot of times we also have a drug issue. Yeah. Most of the women who I know who are affected with HIV got it from their partners, their straight partners who are IV drug users. So we also have a problem with drugs in the South. We don't have needle exchange programs because our representatives say, if you give them those needles, they're going to do more drugs. Well, let them do drugs without catching HIV or hepatitis. Some of our representatives. But let people do drugs without contracting HIV or hepatitis C. At least with the exchange program, you have an opportunity to work with but you still not ready to move on, But you just show them and identify them, they're never going to come see you. So we have got to do a lot more in the realm of harm reduction strategies. Our state has an abstinence-only education for sex. Abstinence only didn't work with unmarried mothers. It has not worked with HIV either. Mm-hmm. So what do? Do you keep doing the same thing or do you change it? Unfortunately, we do have representatives like you ladies who are working to change that, but there's so many negative factors. And then when you go back to the racial part of it, the people who are against women having autonomy over their body, the people who are ignoring black men being shot down in the streets, the people who are ignoring HIV, guess what? They are the same people. They're the exact same people. So, that's my soapbox.
So, I love AIDS in Alabama. Talk about your housing programs, talk about your transportation programs. You guys are doing some amazing work.
Amazing work. I want you to choose Alabama is progressive in some areas.
So, AIDS Alabama is the largest ASO in the state, really the fiduciary agent for most of the other AIDS service organizations. We have housing. Our motto is housing is healthcare. When you think about the hierarchy of needs, if you don't have a place that you feel safe, that you can store your meds, you're not going to take them. It also lends itself to people being put at risk for sex work and other things. You just have a roof over their head. So we have several different housing programs. Hopper funding is one of our main sources. Then we have Ryan White. We also have a 340B program that we just entered into with the 1917 clinic, which is our HIV clinic. So we're actually giving us money to help alleviate some of the housing issues, because in the South, when you're poor, housing is a big issue. We also have mental health services. When you go to an HIV clinic, when you want to see a therapist, you may have a 3-month wait. Well, you may not be able to wait 3 months. So last year we opened up the Living Well Outpatient Center, which does telemedicine for mental health, and we also have licensed therapists on hand. Transportation. Anybody live in Alabama besides me? So you ever got on the bus? No. Yeah, you stopped out there. Our transportation system is terrible. If you have 2 appointments during the course of one day, you have to decide which one is the most important. Because if you rely on public transportation, you're not going to be able to make both of them. You're going to have to get up at 6 o'clock in the morning to make a 10 o'clock appointment, and then it takes you another 2 hours to get to the next appointment. So we actually we do thousands of transportation runs per year. We actually have gotten some additional funding to help with adolescent care as well. We also have a lot of kids who are infected, from 18 to like 24. I just started a program for them to help them transition into adult care. So we help them figure out how to make an appointment. You know, think about your first medical appointment. Who made it for you? You know, and some of these kids, if you're identified as LGBTQ on any part of the spectrum and you're HIV positive, your folks really don't want to have anything to do with you. So you're really on your own. So we're really trying to make sure that our patients or clients have the things that they need. We do a lot, and we really do a lot.
Listening to all of you, one thing I was thinking about is so important, and it's number one with us, healthcare, and that's, you know, what we're looking toward November, but we're working on things now so we can hit the ground running in January. But when I think about the thought that they want to knock off pre-existing conditions and how that would affect, you know, so many people, and even I would think business-wise, it would affect people too. Can you talk about that? Deja, or you guys?
So go ahead. Yeah, I'm happy to. The thought of losing I was very fortunate to spend some time working for President Obama running the Office of Maintenance Policy, and we designed our nation's HIV strategy based on the fact that we had an Affordable Care Act, and based on the fact that it contained the pre-existing condition piece. And to think that we would lose that is personally frightening, and I don't mean for myself, but as a human being, thinking about people whose lives could be devastated financially, which then ruins marriages and families, and I mean, just the repercussions of that, I think, are so paramount that for us to be united in saving that. And I don't think it used to be even a partisan issue. It's a healthcare issue, you know, it's a health equity issue. So the idea of the very thought of losing that feels like it would set our nation back tremendously. I also want to say, you know, when you think about pre-existing conditions and then the limits and the caps that they put on those, told me, for instance, my surgery was over $300,000. You know, we have a $100,000 cap on services that you can get for one ailment. But what happens if it comes back? Because we know cancer doesn't go away and stay away forever. Sometimes it comes back. So what do? You already can't get insurance because of pre-existing condition clause, right? And I use cancer because, again, cancer is a little bit more sympathetic to the average person than HIV. But it's the same thing. You know, not only can we not get health insurance, try to get life insurance. Try to get life insurance.
So hard.
You know, it's almost impossible to get decent life insurance. So, you know, while all these corporations and fat cats are making all this money on the backs of poor and middle class people, they're not doing us any service. They're just getting fat and rich off of us. You know, why would you pay $300-400 a month for an insurance premium, but you can't get the care that you need? Or have that be over half of your take-home salary. That was another thing I like about the ACA. You know, they had that cap on it. Your insurance cannot be more than 10% of your, I think it was 10 or 15. I think it was 10% of your pay. Because you just can't, once you pay your insurance, you have nothing else to eat.
I have a personal story about that, you know, before the ACA, as an entrepreneurial filmmaker. You know, I'm a lawyer, but I took a different route, and you know, I made the choice, you know, between the $800 premium or, you know, my expensive rent in New York, you know, and eating. Like, it was that. It was, you know, affording $800 as an artist or an entertainer was not an option. And then I got pneumonia. And they thought I might have had TB, and so they quarantined me. So I was in a quarantine room with pneumonia for 5 days. My bill was $217,000 with no insurance. It forced me to file bankruptcy, and you know, this is someone who paid his bills on time, all the time. I had a 800 credit score, so I was not an irresponsible person. But I got sick, and I didn't have health insurance, and I had to make the decision every month between health insurance and just basic things. And so when I hear people talking about the ACA and taking it away, it is a very personal thing to me because it changed my life. I never, and the shame that comes along with filing bankruptcy over something that I didn't have control over. And that, I think, those are the human stories that people miss. And this is someone who is I pay my taxes on time every year, and so anyway, I really hope, we get it done in November.
Catastrophic events happen, and I just think that we as Democrats, and I know we're nonpartisan with the foundation, but I think it's really important that we fix the ACA. It's not functioning the way I wasn't here, neither one of us here to vote on it initially, but we both voted over 60 times to keep it every time that it was threatened. And that's because we really understand that the quality of health care and access to good quality health care, it's a basic human need. And in this great country that we live in, no one should go without health care insurance, or no one should feel like one catastrophic health care event would wipe you out like that. So how do we spread the costs? The reality is that the cost is rising too. And we need to do something about the rising cost of healthcare, period. But when I think about pre-existing conditions, I think about the fact that I was born in a family that has hypertension, that has diabetes. I am predisposed, out of the gate to certain things. And so the pre-existing condition affects all kinds of diseases. My question I kind of want to get back to the heart of how do you afford medicines when you're HIV positive, and how do we as society do a better job of controlling the rising costs of medicines?
So I had a little feedback. I'm going to put my policy nerd hat on, if that's okay. It's not going to be as emotionally compelling, but it's the nerdy part. One of the things that I see as a community-based organization, and I have an interesting lens, because on one end, I work in direct service. I run a CBO in a very underserved rural region of Southern California, very, very remote place in the desert, but I also served on the President's Advisory Council, and it was very interesting making that connection, because I got to see how the sausage was made. Yeah. Right? And I became very passionate about regulatory policy. And what I found is that there's often this passionate charged spirit with legislation. Right? We look at these frameworks and we're so excited by it. And then once it's implemented and it's handed into the hands of the administrative agencies, excuse my language, it's all fucked up after that. And I saw in 1 month my cost per patient go from $866 per month to $1,900 per month, and it was over regulatory measures that were lowered on from federal to state to county. And what happens is that once it gets down to the county adheres to federal regulation, then the state receives the funds, they add in state regulation, then they sub-grant it to the counties, and the county creates their own, and you've eaten away all the administrative indirect allowance, and you're left with these hurdled policies. And so again, I'm just going to urge us, it's great to think high level. It's great that we have these large, grandiose frameworks for how to solve healthcare, but if we're not doing the real work of seeing how it's implemented, you're not going to see agencies like True Evolution or AIDS Alabama or GMAD. You're not going to see us survive. Because for every story of success, we all have our stories of Charlie's just trying to keep the lights on and the doors open, and so I would really encourage all of us the recommendation I would give is after we look at the legislation that is needed, that there's the follow-up and that aides are really digging into the administrative functions behind it, because it makes a huge difference, particularly around cost.
Very good.
Yeah. So we realize that can you hear me? Sorry. That medication is very expensive. We see some of our patients maybe not being able to afford medication because it's so expensive, but great programs, even like those that Gilead has, where our pharmacists and technicians are able to identify that barrier. If someone's having a financial issue, there's copay cards that are available. If they don't have insurance, there's programs that are available to get somebody treatment, and our pharmacists are very good at identifying those barriers.
And I think information. I think, I've lived in New York, California, and Illinois, so I've never lived in the Deep South. But when I go to the Deep South, with this film.
There's just a lack of education and information because there are programs out there, but they don't know that they exist. And so we have to do a better job of getting information out there, because that's actually, a couple of people have said that to me after screening, is that they're scared to get tested for HIV because they think that they may be, infected, but they don't have health insurance and they don't know what to do if they do become positive. And I think we can do a better job in many areas of getting the information out there that there is available, resources.
That sounds like another movie to me. Khadijah, I wanted to ask you, with the services that Walgreens gives, have you seen an increase in customers, or have you, for AIDS, or or a certain age, or what have you seen as we move forward?
So what I really feel passionate about is we've actually seen, the increase in our HIV treatment patients grow because we're able to keep them adherent to their medication, and then also just even the last year, the number of patients that come to us for PrEP, every single one of our 8,000 stores has dispensed PrEP, which is extraordinary. So I think people are becoming more and more aware that it's accessible, and our pharmacies carry the drug and are knowledgeable of the drug and are able to support people.
Just quickly, because we have the opportunity, we have an audience of Black people here, and I want to follow up on that. And certainly I'm not here to push Gilead's drugs, but I think the awareness of the patient assistance programs and support programs that our and other pharmaceutical companies have. In addition to that, there are patient assistance foundations that can help people. And then lastly, thanking you both and the Congress and the United States of America for continuing to support the Nine White Cat. There should be no person in the United States of America who is living with HIV who cannot get access to medications if not for free, for a really, really low cost, and then the companies can support them. So I think it's just an opportunity, and that counts for both prevention for PrEP and for treatment.
One other thing on the drugs, so Gilead and there's some other companies that do an excellent job of, once you're in the system, letting you know what you can do. And I think a lot of times we don't listen because it doesn't affect us. The average person not trying to hear about Gilead's co-pay assistance program because they don't have HIV. It doesn't really matter until they got it, but we still need to try to put those messages out there. But another thing from the movie, and people don't think about it in such a broader context though, but when we think about ending the epidemic, like even without a vaccine, we have everything in our toolkit right now to end HIV. But there's one thing that's stopping it. So let me tell you how we end it. People who are HIV negative, who are having sex without condoms, which is just like all y'all. Nobody's using condoms. I mean, seriously, get on PrEP. If you take PrEP, you can't contract the virus. People like us who are living with the virus, if we take our medications, we can't pass it. So if negative people can't catch it, if we can't pass it, what happens in the generation? It goes away. There's that one little word, stigma, that really messes up everything we do. Stigma has many different forms. When we say stigma, it's just not one form of stigma. Stigma stops people from getting tested who need to be tested. People stop people from, once they got tested, going to get treatment. It stops them from going to Walgreens and getting their medication, which is more convenient for them than traveling 2 hours to the CVO or the medical place that they get treatment because there's a shame. What if one of my friends see me getting this medicine? And pushing out on people who are negative, y'all got to change the way you talk about HIV. You have to change the way you talk about it. It's in your churches, in your everyday lives. Someone finds out one of their friends has HIV, what they do? Girl, she got that shit. And that's what y'all say. That's what people say. Imagine me, if I didn't tell you I was gay, most of you wouldn't know. If I don't tell you I'm HIV positive, my fat self, you wouldn't know that either. But imagine saying that in earshot of somebody who is quote unquote passing. Imagine of the burden that you just put on them. And people do it every day without thought. Without thought.
Can I just say this one real
I
quick
just
thing?
want to prepare you guys that it's your turn now, so whoever has questions, if you can come to the front. We're going to scream from the back. Nathan, say what you have to say, then we'll go to questions.
Just a quick thing, and that people ask me why I chose to make it a heterosexual couple, and that's exactly why I did.
I love the fact that you did.
Because, I wanted to be invited in spaces and places that, unfortunately, if it had been a gay couple, we wouldn't have been invited to. And I think that opened up the window for us to show this film at churches, at the National Action Network here, and we do really need to fight stigma, and because it's not a them disease, it is a disease that is ravaging our entire community.
And actually, my best friend, I talked about the person she married. His sister was heterosexual, and she died from the first person she ever slept with.
Mm-hmm. Yep.
This was a long time ago. Before
It is not a numbers game. All it takes is one.
Sir, it's in the back.
Rick Blake, it's on? Well, it doesn't matter.
It's
on. Okay. Oh, there we go. Rick Blake, Strategic Health Resources. Before we start patting pharmaceutical companies on the back, I think we need to know a couple of things. One is that some of the pharmaceutical companies are here for their investors and their profits. That's it, period, end of story. So before we start doing that, we need to look at those particular pharmaceutical companies and biotech companies that are withholding pharmaceutical drugs to the market, and there are many of them. Particularly for HIV comorbidities, sorry. There's one now in the state of New York, and before we start patting Governor Cuomo on the back, I think ending epidemic 2020 is sort of an empty soup. By now they spent a lot of money, but they haven't really had a lot of results. So at the end of the day, then let's look at long-term HIV survivors with huge comorbidities, particularly for cardiovascular disease, stroke, heart disease, and gastroenteritis. Those particular HIV patients, there are about maybe 200,000 HIV patients currently in the state of New York. That's accounted probably a lot more. I know several personally that are dying not because of their lack of access to either PrEP or ART, but because of lack of access to drugs that ameliorate their comorbidities.
So, do you have a question?
Yeah, okay, so the question is, Congress needs to put out a bill, a piece of legislation that focuses on the co-conditions of HIV. And PrEP, by the way, is not a cure. PrEP does not cure the antiretrovirus, and it just lowers the count. So that's really all it does. So the question is, are you willing, Congresswoman, to support a bill that supports medicines and therapies for long-term AIDS survivors?
Of course we are. Come to our office and visit. You'll be seeing the person right there. Just took the mic from
Can I say something? I actually would know. You said you personally know people who are dying because they don't have access to PrEP.
No, I didn't say that. I said no access to the drugs that are co-conditions, not PrEP itself. Mm-hmm. I think PrEP is more.
So let me say this. So pharmaceutical companies, are they the best in the world? They're okay. Can they be better? Yeah, we all can be better. I don't know if you were here when I told my story, but when I was diagnosed, people were literally dying from the medicines that the pharmaceutical companies were making, and they were doing the best that they could. Right now, I didn't interrupt you, sir. Right now, I have a $60 copay that, thank God I could afford. But you know what? Thanks to a couple of assistance funds, I can get the medicines that I need at no cost. There are always going to be problems that we have, but unless we decide that we're going to work together to fix the problems, I have a comorbidity. I'm a long-term survivor. And you know what? the issues that you bring up, they're valid. But I think that we need to figure out how to work together with pharmaceutical companies, CBOs, the legislature, in order to get this done. Because it's not, you can't lay the blame at just one entity's feet.
Yeah.
Thank you.
All right, thank you. My name is Dr. Michael Knight. I'm an internist. I'm a physician here at the George Washington University as well as with the National Medical Association. So thank you so much for your panel. And the film, I think, was amazing. As a physician here in DC, one of the things I constantly see is that even as healthcare providers, sometimes we're not always having sex-positive conversations with patients. I can't tell you the number of young Black patients that come to me that have never had conversations with their physician about who they're having sex with, what their risk factors are, have never been offered PrEP. Even in my own, unfortunately, institution, we've had patients who would come to me and say, I'm in a relationship with a HIV positive partner. I have no idea about PrEP. I'm scared, even to do anything because I know nothing about what the risks are. So even having those conversations as someone who went through medical school and residency, it's really, for me, really seeking out this information. So how can we continue, not only to the general population, but to our healthcare providers, because all of us need to be educated on this. How can we have more sex-positive relationships and not have so much stigma, even from healthcare providers to our patients who need this information?
Your institution, the GWS School of Medicine, is doing an extraordinary job of training first-year medical students, and they actually had a program with us in the Obama White House where they brought them, the students to do programs to present on projects that they worked on. I think that program needs to be replicated across the country in all our medical schools. So they spend, I think it's an entire semester on HIV, working on an HIV project, these first-year medical students. And so as they go through their education and through school, they're aware of it. They spend time in the hospitals, interacting with patients, interacting with community-based organizations. And I think if we could have that be standard practice in medical schools, it would change the way that the interactions.
This is another plug for entertainment. A good friend of mine, my little sister from high school, is a doctor, went to the University of Chicago. I sent her my film. We were at this women's expo. She's about to be on Married to Medicine, Los Angeles, but she's amazing. So she's not going to embarrass us. But she's invited us to be a part of a taping where we're going to show the film, and the film helped her to start talking to her patients differently. And now we're going to have this national platform where she, as a doctor, is going to talk about the use of other mechanisms to talk to patients, and using entertainment, and using unconventional, non-traditional methods of talking to patients. And so another plug for taking the entire community and all of the different things and talents that we have in the community to use it to get the information out.
Can I say one other thing? Y'all gonna be tired of me talking about stigma, but the concern that you have is also centered around stigma and ignorance. So stigma comes from patients. I have patients who their doctors don't know that they're gay. I have a friend, 63 years old, who lives in Atlanta, who I finally got him to get on PrEP last year, but he had to go to Mason to get on PrEP because he didn't want his doctor to know that he was gay. I couldn't have a doctor who didn't know who I was. How are they going to help me? So that's again, self-imposed stigma. But then, Birmingham is one of 2 cities in Alabama in which doctors will actually prescribe PrEP. You go to Mobile, they're going to tell you no, because I'm not going to give you this medicine for, and there's nothing wrong with you. Well, we're trying to stop it from being wrong with me. That's why they call it pre. But doctors have to do it, and I'm glad they're doing their program, but there are doctors who've never even heard of PrEP. Never even heard of it. Internists. There's got to be something about continuing education as well.
So I know Dr. Neva Rubin-Johnson very well, so you need to tell her with training for the MMA. So.
We've definitely
One
had
last
that.
question.
Oh,
Yes. Thank you, panel, for the conversation. My name is Stephanie Holliday, and I'm a pharmacist. I've been working in the specialty pharmacy and managed care niches of the practice for the last 10 years of my career. And the question I have is about quality measures. And there's a lot of work being done within CMS and other organizations to help help assess the quality of the health care that's being provided to American citizens. And the best part about all of that, I guess the silver lining, if you will, is that these quality measures, because they are tied very often to reimbursements for providers, for payers, for institutions, it's helping to elicit change in how care is delivered. So my question is, just are there any initiatives that you all are aware of that could potentially impact the education, the access to care, the access to medication with regards to HIV and AIDS through quality measures?
Actually, yeah, there was. And then I actually, Douglas would probably know more of the history behind it than I would, but during the time that I was on the President's Advisory Council, I know that Dr. Ada Adamora and Dr. Ligia Peralta, who led our Access to Care Committee, were looking at HEDIS measurements specifically and how we can be modeling after Ryan White. So for those of us that do have Ryan White is the creme de la creme premier of standards in care. The standards of care are often also regulated at your local planning council as well. So they're very much like community-driven standards of care. And I know that during our time there, we were looking at how we could be working with CMS to integrate similar benchmarks that Ryan White has into HEDIS measurements. But I will just go ahead and put that advocacy moment that we were abruptly dismissed by number 45. So we, our work on that dissolved at the time that we were dissolved.
But I would say to you, I think this will be a great opportunity for you and others to do to go on the Hill and meet with legislators and do a briefing on outcome measures and quality measures in care. I think it would be a terrific opportunity.
We would welcome that, actually.
There you go.
Especially, I just got on Ways and Means, and I'm in the healthcare subcommittee, and I have a wonderful LA, Hillary, where are you? Wave your hand. So and I know Robin has an amazing LA who does healthcare with Mia, yeah. So we welcome the opportunity to get it right, to get it better, and I think that only comes from having good partnership with professionals that are actually doing it every day. So thanks.
Congresswoman, your question that you had asked me was very specific, and you said homophobia.
No, homophobia.
Homelessness, but then you framed it around black and brown and homophobia and how that influences homelessness. But I would be remiss as an activist if I did not talk about the impacts of transphobia and how within the spectrum of the LGBT community, there's a subpopulation that even we are guilty of marginalizing. And that black transgender women are not only being murdered and slain, not only at the hands of violence, but they're also being taken out in numbers by the HIV epidemic. And I just would not feel honored to my sisters or siblings in the trans experience if we did not highlight the fact that they are falling deeply in the margins.
Yeah. Very good point.
Asher, what? There's a moment of silence at 3 p.m. Eastern. Can we give a round of applause to our panel? They were fantastic. I was getting the eye. So our next panel will discuss maternal mortality and morbidity. So please stick around, and thank you guys so much. And of course, we have to take pictures. Okay. Yeah, you guys sit down. We'll stand behind you.
I want to ask the members of the next commission, the panel, to convene to my right, or your left, over here. If you're on the next panel, the next commission, please convene over to my right. And to wind down those very important conversations and networking that I know is happening and we encourage, but we also want to make sure that we can stay on schedule. Also, if you are on the next commission, if you're a panelist on the next commission, ask you to make sure you get mic'd and make your way to the stage at this time. Thank you so much. I don't know about you all, but this has been so engaging, and I feel like we could just spend a day on each one of these and still not cover everything, but this is a beginning, not an ending to the conversations that we're engaged in today. And so I want to encourage you to carry them forward and continue to work with your peers and colleagues. I want to thank everyone who's on the last commission for their insight, and those of you who are in the audience for your questions. The next Truth and Reconciliation Commission is going to take a look at maternal health. Maternal health. This has come up already today a number of times. And as the panel settles in, I'm going to take this opportunity just to introduce the moderator of this commission discussion, Dr. Latasha Perkins. Dr. Perkins originally is from Biloxi, Mississippi. Did I say it right? Dr. Perkins is a graduate, of the University of California, Davis. I said that because I'm from California. And the University of Alabama, Birmingham School of Medicine. She completed her residency training at the Spartanburg Regional Family Medicine Program in South Carolina. And she is the former Health and Media Fellow of Georgetown School of Medicine's Department of Family Medicine. And with that, I'm going to turn the floor over to Dr. Perkins.
Hello, everybody. Can you hear me okay? All right. So as Cameron mentioned, I'm Latasha Lee. I'm a family medicine physician by training. But you are not seeing things. This is not a food baby. There is actual baby bump here, 21 weeks and 5 days. So I'm both professionally and personally invested in this issue, and it's close to my heart, both literally and physically. And husband's in the audience, Wayne Gill. Yay! All right. So today we're going to get into a great conversation about maternal health, and we have a dynamic, illustrious panel. I'm honored by being on the stage with these ladies. We're going to touch on issues such as racism, equity, issues of imaging, and even media. So I'm going to start with just a brief introduction about each of our great women on the stage, and then we'll go into just an opening statement from each of you, and then we'll go from there. Keeping in mind, we are taking questions from the audience, and so we'll either write them down and have someone come by and pick them up, or we'll open up the floor for microphone questions, because this is to be a conversation. So while we're doing the bio and the opening statement, please be thinking of questions so we can interact and have a great conversation. Is that okay with everybody? I know it's lunchtime. I'm glad you're here. We're going to make this great, okay? All right, so our first panelist is Ms. Jane O'Donnell. She is the healthcare policy reporter at USA Today, where she specializes in patient safety, mental health, and other important issues. She's also a co-founder of the Urban Health Media Project. So this is Ms. Jane O'Donnell, so everybody give her a hand. Sorry, we mixed up the numbers, I have to go by the mics. So, next is Ms. Stacy Stewart, president of the March of Dimes. She joined the March of Dimes as the fifth president January 1st, 2017. And in her role, she heads the organization leading the fight against health of all moms and babies. So that's for the health. For the health. Not against it, but for the health. So this is Ms. Stewart. So everybody give her a round of applause. Next is Dr. Joya Claire-Perry. She is a OBGYN by clinical training, but the founder and president of the National Birth Equity Collaborative, and she also served as the executive director of the Birthing Project, director of Women's Health and Children's Services for Jefferson County Community Health. Mm-hmm. So that's Dr. Perry. Give her a round of applause. Next is Ms. Linda Goler-Blount.
She oversees the strategic direction of the Black Women's Imperative Health, Black Women's Health Imperative, and is responsible for moving the organization forward in its mission to achieve health equity as well as reproductive justice for Black women. Thank you, Ms. Blau. And that, last but not least, is Ms. Elizabeth Dawes-Gay. She has an MPH and serves as the co-director of Black Mamas Matter Alliance, and it focuses on advancing Black maternal health, rights, and justice. And she's also the founder of Issue Consulting, where she works with organizations and individuals to advance social, racial, and reproductive justice for women of color. So give our panel a round of applause. And so each of you ladies can give a brief opening statement. I will cut you off to get too long. Just letting us know what's important to you. What do you think our audience should be thinking about when it comes to maternal health? And we'll go from there. So we'll start with you. Okay. All right, thank you for moderating this panel, and thank you to Congresswoman Robin Kelly's office for the invitation and for hosting this important conversation. As the moderator mentioned, I'm Elizabeth Gay, I'm co-director of the Black Mamas Matter Alliance, and we're a relatively new effort established in 2016 to work on advancing Black maternal health rights and justice. We have a vision of a world where Black women have the rights, respect, and resources to thrive before, during, and after pregnancy. And so we work with over 40 kindred partners and collaborators to achieve that vision. These are people who are all across the United States running Black women-led organizations, efforts, and initiatives that focus on creating policy change, that are generating research that's meaningful to our communities, that are advancing and promoting holistic care of Black women, ensuring that we have the highest quality of care, and that are working to change the narrative, how we talk about and think about Black women. So our work is important because, and then I'll stop after this, I know we have to get to the other things, but our work is important because there was no national voice dedicated to Black maternal health solely, right? A lot of people were talking about infant health or women's health overall, but there was no national voice and coordinating entity for those groups who are working on advancing Black maternal health. So we have a model that involves listening to Black women, trusting Black women, and investing in Black women. And we especially emphasize the last point because we know that there are these groups, there are efforts all around the U.S. that are doing this important work with very little to no resources. And so in order to create the sustainable change that we're seeking, we have to invest our dollars and our time accordingly.
Excellent. Well, good afternoon. I'm Linda Villa-Brown, President and CEO of the Black Women's Health Imperative, and I too want to thank you for moderating this session. And so, Congresswoman, this is so important. Thank you for doing this. The Black Women's Health Imperative is now in year 35, and we're the only national organization focused solely on the health and wellness of the nation's 20 million Black women and girls, and have been so for 35 years. Which in and of itself is really sad to think that there's only one and has only been one. I get to work with these women who are amazing, and because we're the Black Women's Health Imperative, we do all things Black women's health, which means there is way too much for this organization to do. We're focused on chronic disease prevention. We have invested over $20 million in preventing chronic disease among Black women just in the last 10 years. Reproductive justice is one of our pillars, HIV prevention and awareness, and obviously policy. And since I've been on board in the last 4.5, 5 years, we've gotten into research translation, and you'll hear a lot about that. But the fact is, in this particular area of maternal health, Black maternal mortality and morbidity, there is a lot of research that I'll bet very few of you in this room even know exists. It goes back to 1992, and we'll talk about that. And so we, as Elizabeth said, talk about changing the narrative. We've got to change the narrative about Black women and their health, because the message that we get every single day is it's our fault. Right. And if you leave with one thing, it is not our fault. We are not crazy. We are not doing things that don't make sense. In fact, we're doing the things that make sense for us because of our lived experiences. And so it is up to all of us and all of you to make sure that the healthcare system serves us so that we can have the best possible outcomes that we're working for every day anyway. So thank you.
Well, good afternoon, everyone. As we said, thank you so much for moderating, and of course, Congresswoman Kelly, and I vote that I do without Mia. I have no idea. Mia saves me every time, so thank you. And Brandon, and the rest of the staff. It's an honor once again to be a part of the Health Braintrust. This has been home for me. Some of you, I see these faces since I've been coming here since Hurricane Katrina, and how the importance of this space and this venue is for Black people and health. I kind of feel like I grew up here. I'm still growing, right? So I am the founder, as was mentioned, of the National Birth Equity Collaborative. I also have the privilege of being on the advisory committee for the Black Mamas Matter Alliance and the Kidney Program, yes. And I also have, for the last 6 years, have been on the board of the National Medical Association. So I'm proud to represent all of those things in one human being today. And really, for us, the vision of the National Birth Equity Collaborative is that every Black baby live to their first birthday with their family, right? And that's however they define family. Family for Black folks is grandma. Family for Black folks might be a same-gender couple. Whatever that means, it's important that we have that capacity to be able to do that. So what that also means is recognizing the historic traumas and current traumas that we experience as Black women in this country. And so why the Black maternal health conversation is so important is because the fact that Black women are dying at 3 to 4 times the rate of white women in this country shows that it is not, despite our income, right? Despite our education, despite our access to healthcare, we still die at higher rates. So we have to be able to have an honest conversation of the impact of racism on our health. If we can't talk about racism as Black folks, who's going to talk about it, right? So we have to really frame that conversation that it's not that we're calling people evil or bad. Racism is a historic and current fact in America. There is a belief in a hierarchy of human value based upon skin color, which translates into how we are treated, both on a structural and individual level, and it impacts our health and our ability to thrive. So hopefully we'll have bigger conversations about our money bill, because we're having some truth in here, some truth about reconciliation. So talking about that is very important, so thank you.
Great. So my name is Stacey Stewart, I'm president of the March of Dimes, and I'm going to join in the chorus of thanking Congresswoman Robin Kelly and Mia for the invitation. Thank you all for moderating, and it's really an honor for me to be joined with all of us that are here, because I think of a lot of us and so many others as being in a real fight for the health of moms and babies, and that's what the March of Dimes really is about. A lot of folks know the March of Dimes. We're in our 80th year as an organization. We've been around a long time. And I'm the 5th president and the first African American to ever lead the organization. And I say that because I think we are, it kind of comes at an interesting time, because as we look at a lot of the outcomes around moms and babies, I think it's pretty striking and is incredibly alarming that when you look at any major outcome with respect to moms and babies, the U.S. is doing incredibly poorly, and we're often at the bottom of the list in terms of outcomes as compared to other industrialized countries. So whether it's around maternal mortality and morbidity, whether it's around premature birth, which is the leading cause of death for children between the ages of 0 and 5, whether it's around infant mortality, our outcomes are the worst in this country. And look how much money we spend in this country on the healthcare system, and look at the outcomes that we're getting for all of that money that we're putting into the system. So the March of Dimes has been around. A lot of folks know about us because of the days of polio. It's an honor to work in an organization that's actually taken on a major health crisis in this country and actually solved it. There are very few organizations that can say that. From polio, we're now working on these issues around moms and babies, all these issues primarily around prematurity, but increasingly we look at the full scale of the issues that impact moms and babies, because it's really not possible to create a healthy baby in 9 months. Right. It requires a woman to be healthy before pregnancy, during pregnancy, and increasingly we're all focused on these issues of maternal mortality. However, I would say that these issues have been going on a long time, and I know we'll get into it. The fact that maternal mortality rates in this country have doubled in the past 25 years, I think, is the reason we're all here, in addition to not just the mortality, but the morbidity, which is a huge issue, and we absolutely must talk about that. But it's an honor for me to be here. I'm looking forward to getting into all these conversations today, so thank you. So as the journalist on the panel, I am here to learn and more from these very, very talented and knowledgeable women. However, I have things that I'd like to share. I have not been someone who covers maternal mortality, but I've been writing about health disparities. I've been writing about patient safety, and it doesn't minimize anything they're saying, but I just want to make the point that we're all in trouble when we go to the hospital. And I was talking to a woman on the way here who I won't mention, but who's very senior, she's white in the patient safety community, and she says everyone she knows, no matter who they are, pulls every string they can if they have to go to the hospital because they're all scared to death because they know how bad it is. So I loved the term, and Linda and I are going to talk after because we've never met face to face, but we've talked a lot. Because I love the term because of our lived experience. Because just to briefly say, the Urban Health Media Project is what I call my second job. Someone said, well, it must be hard when you have a day job and your passion, but they're both my passions. I'm one of the lucky people that works a lot and loves everything she does. So I'm working with African American high school students and some college student interns in DC and Baltimore. With others, I'm the only white person. There's one other white woman who's an editor, but the people that are working are African American reporters, and we're teaching these young African American reporters, in one case Hispanic, to have a voice and to use their voice and to give others a voice in their communities because and it's so important because I always remember, and even if Congresswoman Kelly wasn't here, I'd mentioned that when I did a big investigation of Washington Hospital Center in this town on all the sewage that was literally on the floor in the surgery room, the operating rooms, and throughout the hospital that nobody knew about. When I talked to her for that story, one of the quotes I used is that she said that when she went in there, she didn't tell them she was a member of Congress. And they want you to tell them if you're a member of Congress because they want to treat them differently than they teach everyone else. And it took a white family to be treated horribly in that hospital, to sue them over the sepsis and all the other complications that happened to this man's wife. And they had two doctors who were daughters, and they're suing Washington Hospital Center, which has I believe still a D rating because of what happened to them. And I'm talking to an African American woman who began to cry because she was so happy she had someone to tell her story to because the same thing happened to her and nobody took her case. So I just used that as an example, and I brought a young African American reporter who's fabulous, who starts in January at NYU with me when I did my in-person interview at Washington Hospital Center, and she was blown away by what she was hearing, and she, even more so than I, noticed how dirty it was and just what the conditions were. And now she wants to get a master's degree in public health after she gets her college degree in journalism. So I just want to set it up. That's my perspective.
Thank you, ladies. It was a good. Let's us know what resources we can tap into for this conversation. So let's dive right in. Racism. Let's talk about it, right? So one of you ladies, two, whatever you want to chime in and tell us what role racism plays in maternal health and kind of what we're dealing with or finding that's coming out in statistics today, currently.
Can I get that? Yes. Because I know Joya's got there's 3 lectures right here. Just to kind of tee up what she's going to say, and she's going to say a whole lot that I haven't thought about. So I mentioned research. So we've got research going back to the early 90s that points to a causal relationship between experiences of racism and adverse health outcomes. So that could be obviously maternal outcomes, but we're talking general health outcomes in general. So, for example, black women have at any point in time 15% more cortisol in their bloodstream than white women. Cortisol is a stress hormone. So there's research that shows that elevated cortisol triggers your body's inflammatory response. So I'm talking like a doctor.
Wow, it's really sexy though.
Because then those might be working out. Which raises our risk for diabetes, heart disease, hypertension, some cancers, changes our metabolic rate. So black women get blamed all the time about our weight. Well, in fact, if you give black women and white women the same high-fat diet, black women will gain more weight and gain it faster.
I knew it. No,
It is not our fault. It is because of the metabolic changes that have occurred. And so you all may say, well, how do you really know? Because there are researchers, Tanea Lewis, Elaine Geronimus, and some others, who have now looked at the DNA of black women. And the very tip of the DNA, these things called telomeres, they're shorter, they're frayed, cell division happens more quickly, cells die, which leads to all of this. And what we see now in maternal health is those same stressors, the body's same metabolic and inflammatory responses are leading to low birth weight babies, maternal mortality, hemorrhaging, maternal morbidity. And just to put a sort of a social frame on it, we tend to think of these adverse health outcomes always, it's low-income women. These are issues of poverty. But while that may be true, there's a difference here, because black women who are highly educated, professional, high-income earners have higher rates of maternal mortality than white women without a high school diploma.
Yeah, so since you did all the doctory talk, I'm going to do policy.
Thank you.
All right. So racism is not just an individual. It's important that we know all those kind of individual facts. But to build on the conversation earlier around hospitals, black serving hospitals are treated like black people, poorly. They're under-resourced. They have less access to, they give fewer resources for dollars, fewer resources for research. And so when you see the impact of that is what you see is the hospitals don't have as many things. If you have a higher risk population that needs to have, for example, an interventional radiologist in-house because you're more likely to have someone bleed to death, but you can't afford to pay that person, that's where the person's going to go for care, and they're more likely to die because the hospital doesn't have the resource for that. So for us, it's really important that we embrace our low-income hospitals, because what happens generally is that we close them, and we know this from DC. What do they put instead? Nothing. Right. So, but we have to work together as community members, especially the black community, to recognize that racism is not just an interpersonal conversation. It's structural. It's systemic. If you pay 70% of the dollar on Medicaid because you devalue the person because you believe that they have less value based on their race, you're less likely to get the resource you need in order to run your hospital efficiently. So I have some great friends who are in this audience who run hospital systems. Okay. So I want to make sure they have the resources they need to ensure that they deal with the racism inside of hospitals. So.
I want to jump in and also talk a little bit. This morning I actually was talking to a reporter and kind of walked them through. I'm going to go back to low-income women because they are an important group. And I think you can more readily see some of the social and economic challenges that low-income black women are experiencing, or that women seeking maternal care are experiencing by looking at low-income black women. So imagine that I'm a woman and I'm seeking prenatal care. When do I have insurance? Right. That's first of all. Do I have a provider in my neighborhood? There are healthcare provider shortages. OBGYNs are in short supply, midwives, doulas, and general practitioners are also in short supply, and that is only growing. So can I actually find a provider in my community? No. I have to go outside of my community. I have to go from Southeast DC to Northwest to find an appropriate provider. When I get there, they see I have Medicaid. They're not actually welcoming to me. They're not nice to me. They treat me disrespectfully. Actually, going back to, I've taken the bus to get there, right? So it's been 2 hours, it's hot and sweaty. I might be in a bad mood. I might have some children in tow that I couldn't find childcare for, who aren't in programs or whatever, it's the summer. So there are any number of hurdles that people have to go through to get to care, and that's not an accident. That is the result of racist policies and systems that have been put in place to keep certain groups of people, black people, in poverty, to keep them undereducated, to keep them struggling with having transportation access, and also healthy food in communities. That's a big issue. We've heard it from focus groups that so many women are traveling outside of their communities, doing different things to get healthy food because the food that's in their neighborhood isn't appropriate. And so they're jumping through hoops to do the right things, to do good things, to protect their health and the health of their families. So I just wanted to paint that picture for you. And then another thing that I mentioned to the reporter was that healthcare, a lot of healthcare providers and some of the spokespeople blame Black women for not accessing care. But we've gone through all this. We've gotten on the bus. We've made it to Northwest. We are in the doctor's office. The receptionist was rude because we have Medicaid. And then we see the doctor, and the doctor treats you poorly. They don't answer your questions. A lot of women don't feel heard. They don't feel listened to. That's why we talk about listening to Black women so much, because we're hearing in doing our activism and our advocacy, we hear from so many women who say, I asked the question and they rebuffed me. I made this complaint. I wasn't listened to. I didn't get the appropriate care. We know that there are women who have passed away who are no longer with us because their providers didn't listen to them. So I think that's I'm going to start using that because I think it's a great way to illustrate like what happens before we even get into healthcare, and then what happens when we get there. And you can dissect it, and we can talk a little bit more about, okay, there are specific policies, there are lack of policies, there are racist things that have happened along this spectrum that influence our outcomes.
So I want to change the picture a little bit. We're talking about policy, the academics of physiology of it. We're talking about the social determinants of health. And I can just kind of use my case as an example, and you guys can help us with this. So I have insurance. Yep. I'm educated. Yep. I drove to my appointment with my husband. The receptionist was another Black woman. She was amazing. She was super nice. We got to the back end. The doctor was welcoming and answering my questions, but toward the end, I felt like there was a moment because before he left, because I'm a physician, I was like, so are we going to talk about advanced maternal age? And he said, how old are you? So he didn't give him a chart, obviously, and you're a Black don't crack. So he was a little confused. I was like, so yeah, about that. Let's have a conversation about what risks I have, what tests do I need to be taking, what things I need to be thinking about genetic-wise, but because I advocated for myself because I knew, but even that was cortisol-inducing for me because I didn't want him to, as a professional, didn't want him to feel like I was micromanaging until he was like, he was about to get up and leave. And I'm like, but wait, I'm AMA. So let's talk about that. So I put that out there to contrast both, and because I ended up changing doctors. But for the women in the room who are childbearing or have daughters or have friends, what are actions that we can take to combat the racism? And he may not have even realized it was racism. He just assumed that, with my life, thank you. But for my health-wise, I needed some more information. So what can we do about racism as individuals to make sure that we can get these numbers to come down in our own, so we're not a statistic?
Well, let me just chime in with a couple of things. One is that DC just issued an incredible report, I think in just the past few days, and it's a whole policy report on what needs to be done to improve maternal wellness here in the district. And our work is national, obviously, but I thought it's a really great report because I think a lot of what women talked about in these interviews, and these were listening to Black women and saying, and asking about their experiences of being pregnant or going through pregnancy, going through delivering a baby. Because I think these are the same kinds of viewpoints that you'd hear from Black women all around the country. And I say they're Black women. I don't know that they're all Black women, but they were mostly low-income women on Medicaid in the District of Columbia, mostly in Wards 7 and 8. So some of the things that they talked about, really interesting, and it kind of points to some of these solutions, really, and this could be for all women. So a lot of women talk about the fact that they rely a lot on the information from listening to each other. So word of mouth is very important. The reputation of the provider is very important. So someone will not go to XYZ hospital if so-and-so down the street or their girlfriend did not have a good experience. All of a sudden they will say, well, I'm not going to go there, I'll go someplace else. But the issue then is, well, where do I go? How do I get trusted information about where to go for prenatal care? Where do I go to, who's a good provider that I can rely on? And the issue of having a reliable source of information to rely on. So one of the things that we need to do is to figure out how do we create more transparency around some of this. Some of the things that go on in hospitals, and your paper did an amazing job of really exposing some of the lack of compliance to safety standards in hospitals, which I think was really enlightening. Some of us already knew it at some level, maybe anecdotally, but I think that USA Today did an amazing article on maternal mortality, uncovering some of why women are dying, and it's because the lack of compliance with safety standards was incredibly valuable. I think one of the issues we have to do is how to increase the transparency of where providers are doing a good job. How do we make sure that that's more available to Black women especially? I think the other thing that was really interesting is that the biggest and the number one recommendation that came out in this report around how to improve maternal wellness was around, and I was really shocked and really pleased to see this, was around something that we're working on, a lot of us are working on, which is around group prenatal care. So a lot of people think prenatal care is always delivered in the most traditional setting, right? I'm pregnant, I go to my doctor, I have my conversation with my doctor, and that should happen, and that we all support everyone getting access to good quality prenatal care. And we know that many women, especially low-income women, are still not accessing that care as early as they need, sometimes not at all throughout their pregnancy. But what I would say is that this idea of group prenatal care, which is actually a concept that's been around for a long time, is an evidence-based program, and it's been shown to reduce the risk of premature birth, but actually help women's health improve overall. By the risk of preterm birth actually decreases for all women, around 30%, for Black women, by over 40%. And we think it's because the group setting provides a social support system. So what women do when they go to group prenatal care is they don't just talk about what they talk about with their doctor. They talk about, you know what, I didn't have a ride to get to my appointment. I need to figure out some other transportation. Did you have that problem? Oh yeah, I had that problem too. Well, this is what I did, right? And the idea of putting women together during a time of pregnancy when you can tend to feel isolated, and you should never feel isolated or alone, or you may not know who to go to for help, that support system actually, we think, serves to offset some of the stress that comes. If people are experiencing challenges and interacting with the formal healthcare system, that additional support they get from other women and getting resources they need, we think, especially in low-income communities, especially with Black women, is incredibly important. So those are just some of the things I think we need to think about is support systems, transparency on information, how do we get that out to more women so that we create a network of support that is bigger and broader and stronger so that all of us get the help we need.
I do want to move on from racism. If you all have questions, please write them down and make sure that we get those addressed, just because there are a couple other things I want to make sure that we get to, one of which is media coverage. It just seems that, African American women, Black women, any issue we have becomes primetime television at some point, or becomes something that's important in the media, whether it's emphasizing it or burying it. So, Ms. O'Donnell, can you tell us more about, from your perspective, the role media plays with maternal health, specifically for Black women, or anything else you think media can help with in this?
Sure, great, and it segues with what I was kind of hoping to just piggyback off on what both Stacey and Joya said. Just really quickly, I just wanted to read the paragraph in the story that was mentioned as a result of the not adhering to safety standards. Women are left to bleed until their organs shut down. Their high blood pressure goes untreated until they suffer strokes. They die of preventable blood clots and untreated infections. Survivors can be left paralyzed or unable to have more children. This is what's happening to everybody, and then it was, as was noted earlier, it's way more likely to happen to a Black woman, whether or not she's very, very highly educated or not. The media, we're obsessed, for lack of a better word, with transparency and secrecy. We're obsessed with a lot of things, sensationalism and all that and that. Some of it's good, though. But we really hate when things are kept from us, as consumers should, and particularly African American consumers, because they're more at risk because of the things that were already talked about. I personally, I'm very curious, and I'll say a little more about the media, but then I'd love to hear more about the idea of embracing some of these hospitals, because there's embracing, but I worry that too many of them are getting way too big of a pass, because in this town, they're D's and F's, and it doesn't matter, and they're run by, I don't know who's in the audience, and it's better for me to not know, whether they're run by all white people or all black people, they're D's and F's, and I wouldn't go if I was shot out front of them if I had a choice to some of these hospitals, and because I do have a choice, but even I would take the chance to go across town, literally, if I got shot. Because I just am so worried. So I really think, I think often I find that African Americans don't tend to call the media, and I love that I do happen to have some African American doctor sources in town, and they tell me what's really going on and how much it's hurting them. So I would encourage everyone to reach out to the media, because I know there's so much negative publicity, and some might be afraid that if we highlighted their case, people would say, well, she didn't go to the doctor until she was X weeks pregnant, and those kinds of things, and there are awful people that comment, say nasty things in comments, but, the legislators and regulators tend to respond to the media. I'm not a boaster by any means, but I'm one of the few people that nationally that does hospital safety stories, and I've gotten changes in what's put on Hospital Compare because I've highlighted what they were going to take off Hospital Compare, and all administrations are very sensitive to that. And they were going to hide some of these horrible infection complications. So I would just encourage everyone to do that. And I also just was curious.
I do have a question for you. So you say reach out to the media. How many people are interested in telling the media a story or wanting to share something with them in the past, or you feel like that's something you're comfortable with doing? Everybody is comfortable and knows how to do that. So as a professional, so what is the best way to contact the media, and in what form, how do you figure out who's the person to talk to make sure that what you're being said is heard and not just going to like the assistant producer and being swept under the desk and not being heard? So what's the best way to approach?
Well, I would imagine that, so I'm not exactly sure what the breakdown is in an audience like this, but if I were, in media we call them real people, if you were just a regular person who had a terrible experience at XYZ hospital, I think the best way, because you probably would be uncomfortable and might say the wrong thing or tell them more than you'd like to have published, I'd be reaching out to some of the groups on a panel like this, finding the advocacy groups, because when advocacy groups call reporters, one of the first things we say is, do you have real people? Because every story needs that. And the story I was posting this morning about the new drug addiction numbers, without the heroin turned to meth addict that from my Cincinnati Enquirer colleague, it would have been a boring government story. So really it's that, reaching out, but look, seeing who's covering it. I mean, if you Google my name, you're going to see a lot of stories about people dying at hospitals, or being raped at hospitals and other fun things.
I was going to say something, which is, I think in addition to what USA Today has done, I just want to quickly acknowledge, ProPublica, NPR,
fabulous.
The New York Times, The Root, a lot of organizations, a lot of media organizations have been doing increasingly such a good job of covering this issue. It does take sometimes a combination of the real stories and maybe an advocacy organization or some organization come together and present the story with some context and then those real stories. But I think on some of these issues now, we're seeing a lot more momentum of how people are covering it, and we need more. We need to expand it. But you raised a good question, which is we should not be afraid to expose, talk about some of these issues, raise them, elevate them. One last thing I'll say is a lot of these issues, and you touched on Elizabeth, and we see this a lot with whether it's a baby that's born too soon and too sick, or whether it's a woman that almost dies or has complications. Many women feel that it is their fault. Right. My baby was born premature because something I didn't do. Oh, I forgot to take my prenatal vitamin. Oh my God, that must have been it. No. Most women want to do everything possible. Almost every woman I know is not, I don't know a woman, I've never met a woman that's not going to do something that is absolutely necessary for her child or for herself to live, to survive. What happens when we have difficult pregnancies, when we have challenges before, during, after pregnancy, we will blame ourselves. Women do this generally. But because of the incidence of these things happening to Black women, I think it happens. We become isolated, don't talk about it, and then it becomes a stigma, and that's where we have to break through. This is not something that should be stigmatized. We should talk about it and deal with the issues that are in hand, and I think the media can be a great tool to make that happen.
And we're going to hear from Dr. Perry.
This is so important, though, really important, because the truth is, if we never challenge the hospitals that don't take Medicaid and we only focus on the hospitals that do, we are creating a media narrative only around safety without saying what would be really safe is if some of these hospitals that minimize and don't take Medicaid patients, who cut off their numbers, who say you have to go from Ward 8 all the way downtown. What is their obligation to the community? When do we challenge the safety of general health of a community and what everyone's obligation is? So yes, it would be great if the hospitals were under-resourced, had more, were able to provide cleaner and more safe places. But it would also be great if the hospitals had a lot of wealth, actually took care of poor people, actually did things in the community, actually did outreach in the community. Like, when are we going to reframe blame equally among all? So that's really the point for me.
And I think media plays a big role. You in media, and one of the things I've learned is that when the story gets out there, then people pay attention. So the cliff notes so far are: share your story, number one. Do not be afraid to talk in a group. Do not be afraid to also go to advocating, get an organization that's advocating for what you believe in. Do some research on who's actually doing the stories and send them your information and just go from there. Because we need action items. It's nice to talk about policy and what's happening and to share amongst each other and pontificate about what's wrong, but we also need to walk out the door with some action items.
Let me add one more. If you feel like you're not getting good care, change your provider. You do not have to stay with a provider if you feel like he or she is not serving you. Just as you did. The doctor works for you, make her do her job.
I want to bring up social media. Yeah, very quickly, because we talked about people telling their stories to the press, but a lot of people are actually telling their stories on Instagram, on Twitter. Black people love Twitter. Black Twitter is a thing. I think it's still. But we have actually, Black Lives Matter has a lot of followers, a lot of people on Instagram, interestingly enough, who are reaching out, who are sharing information, who are telling their stories, trying to get connected with us that way. So I also had a question too, because I've noticed that media also pay attention to social media, right? And so that's another way for people to get those issues to the next level, to have them get some attention, because all these articles that are coming out actually cite Twitter, they cite what people are posting online. And so that's another way, if you don't know how to reach a specific person, just start tweeting about it, start sharing it, start hashtagging, Black Mamas Matter, Black Maternal Health.
Be careful, hospitals and doctors are suing people that tweet about them. So I did a big piece on that. Yeah, be careful with that. Yeah, I did. I can share it. I just do worry that they might really go after people.
So before we end, I do want to give each of our panelists an opportunity to give 1 or 2 minutes of something that you want to leave the audience with. Action item would be wonderful, but also any other information you want to share. And we can start with.
Yeah, I think our blueprint for action is the listen to Black women, trust Black women, and invest in Black women. Donate your time, your energy, your resources, volunteer, get connected to a local Black women-led or women of color-led entity that is working on this, that's working on Black maternal health, that's working on Black women's health. We need your support. We need your voice in this effort. And then join us at our conference in December. We're having the first National Black Maternal Health Conference and Training Institute in Atlanta, Georgia, December 7th through 9th. You've probably seen the flyers outside. Registration is open. And it's a great opportunity to learn more about the issue, to get to hear from experts, what the best practices are, what they're doing, to create change and how you can apply it to where you are. And then also to grow a network. It's a great networking opportunity. We do this work collaboratively. We know that we can't make progress alone, so we need to be in conversation and working with others to make things happen.
And I would say know what's happening in your state. This administration is chipping away at policies that help us to be as healthy as possible, and it's happening literally at the state level. So today, the Black Women's Health Imperative has announced the first ever health legislative agenda for Black women. So it's on our website, bwhi.org. It's about time. But the reason is it gives key legislative and policy issues relative to Black women's health, particularly maternal health. And if you don't know what's happening in your state, if you don't know where your elected officials stand on these issues, you may end up with the wrong person in the office. I can't, of course, tell anybody who to vote for because I work for a nonprofit, but I can say this: vote, know the issues, and vote. That is really one of the important things you can do. And then advocate for yourself whenever you're talking to a practitioner. Do not leave until you're satisfied, until you get your questions answered.
So it's important that you have social support when you're in pregnancy. So husbands are really great. My husband went with me for my 3 children that I have. So having a doula is important. Having access to midwifery care is important. As an OBGYN, we recognize that we need the full spectrum of assistance for all those things that occur. So that really just went to your earlier question, making sure you have that. Thinking about also, whenever you see health inequities, don't think of individual people, think about systems, right? Because policies, big P policy and little p policies create inequities, not people's choices, people deciding. So just like policies created them, policies can uncreate them, policies can undo them. And again, is anybody here from Missouri? Yay, all right, let me say, so I give this as an example for you to understand how racism impacts policy today and creates health inequities. So Missouri is wanting to do a Medicaid expansion for opioid-addicted mothers, which sounds amazing. But why they pick opioid-addicted mothers is because they perceive those women to be white. So if they proceed with this choice because of they value this group of people more, 10 years from now, you will see better health outcomes for white women than you would see for Black women. So it's important that we understand that when we see health inequities, it's not individual choice, it's policy. Okay.
Thank you. I want to pick up on what Linda said, and I'm so pleased to hear about the policy agenda that's been rolled out. That's awesome. My biggest point is that we have midterm elections, and there are a whole range of issues of why people want to go out and vote in November. I would say that from the March of Dimes, one of the things that we want to encourage people to, and not just encourage, urge, stress, push everyone to focus on is that in this country, we do not have a policy environment that is supportive at the level it needs to be for women's health, for women's health while they're pregnant, after they're pregnant. We have a broken system that is really failing all women, and it's failing Black women in particular, and that just shows in all of the outcomes. So the evidence is clear. And if we're going to change the trajectory, there are lots of things that have to be done in terms of how the practice of healthcare in this country. But at the highest level, we need elected officials at the highest level in this country to change their viewpoint of what this country needs to do to prioritize the health of women, the health of pregnant women, so that we have better outcomes for all women and better outcomes for babies overall. So our point is going to be that we don't need incremental change, we need blanket change. And you're going to be hearing more about that from the March of Dimes soon. But we're going to ask everyone and give people the tools that they need to make sure that you have the ability to, whether it's a Republican or a Democrat running in your congressional district, both of them, either one of them, both of them need to be supporting these issues. And there's a way that you can use your voice to encourage them to take a stand for the health of moms and babies. So more to come.
I just got a story idea. I love the actually a mini story. Very specific. Opioid addicted mothers. That's actually very interesting. And I'm hoping to connect myself and with some of my colleagues with some of the people on this panel, because we have been talking about very broadly defined, because I don't want to give away my story, but just on how women generally are treated in the medical community and African American women in particular. I'd urge everyone to look at ratings. There's so many ratings out there. I think word of mouth is great, but I also think leapfrog.org happens to be my favorite that I use. It's easy to use, and it goes to another level than what Hospital Compare does. I just want to say, as I'm not telling anybody anything, I'm just saying as an observation, the work I'm doing with my students, we're working on mental health, the stigma around mental health treatment, and if so many of these young people I've come across and interviewed and worked with are not getting basic medical care at all, or they're so leery, and I'm no fan of the pharmaceutical industry, but they're not taking anything for things as extreme or serious as bipolar disorder. So I just do worry, and there's a lot of, my story today shows there's a lot more use of marijuana by young people, including pregnant mothers, and there's just so much more that needs to be done in this area, and I'm excited that I'm going to continue to be able to do it with the help of people on this panel.
Yeah, absolutely. Congresswoman Kelly?
I just wanted to say, first of all, thank all of you so much, but also a couple of things that were said, and this is Robin Kelly talking, not TCF, but when you talk about the importance of voting and knowing where your particular, I'll just say, congressperson stands, because I have a legislation, the MAMA Act, to help with maternal mortality and morbidity, and I'm just saying, I don't have one Republican co-sponsor.
Right.
And it's not a red bill or a blue bill. It's not partisan, because it's all kind of moms. Yes, 2 to 4 times more African American moms, but all kind of moms from all over. Doesn't matter your education, as you guys know, your wealth and all of that. So if you live in one of those areas where you could, call, write, do whatever you can do to help us get this bill in and out of committee and onto the floor, that would be wonderful. It's just Robin Kelly talking.
So to sum it up, first give these ladies a round of applause. As well as Congresswoman Kelly for doing such an amazing job of picking this as a subject. But it sounds like we have some action items, right? So wrapping it up. So one thing you want to do is share your story. Get a support group, whether your support group is sisters, family, doula, midwife, doctor, friend, just get a support group. Find an organization that advocates for maternal health issues that you care about. There's a bunch of organizations represented right here on this stage. Vote. Also familiarize yourself with the MAMA Act and also see where your representative falls on that particular act. And ultimately, the word for the day is empowerment. Leave here empowered, knowing that we can take control of maternal health issues, and we don't have to be statistics, right? So thank you all for
and good luck to you.
Yeah.
Wonderful, wonderful. Thank you so much to our moderator and to all of our panelists. I heard someone mentioned incrementalism. And as we take a long view of these issues, I think it's so important that we balance the urgency, what Dr. King talked about as the fierce urgency of now, with that long view, knowing that all of our goals won't be achieved right away, but we have to take it seriously and really work on it. We can't take an incremental approach, as you were saying. So thank you. Another round of applause for our panel. At this time, I'm going to ask, as the panelists take their seats, I'm going to ask everyone to stay right where you are. Don't move, because we're going to go right into our next commission. And so if you need to use the restroom, I understand, but please hurry back, because we're getting ready to wrap up our day's discussions with the TRC on men's health. So please prepare yourselves for that. I'm going to ask the panelists on the next commission to come to the stage at this time and be seated, and we're going to get started. To the back and find their seats so we can get the next panel, or get the next commission and panel. So, as you find your seats, I will say that a number of instances earlier in the day men's health has been referenced or alluded to. And one of the things that seems to be a reoccurring theme is that men are not seeking health care as aggressively as we should. And I think that that is a common sentiment, commonly held. And so this last commission is very important as we think about men's health and health equity and what that means for us moving forward, particularly among men of color. And so please do give us your full attention, your intention, your ideas and thoughts, because we're going to dive in on this very important subject. And I want to take this time to introduce the moderator of this commission, who's a dear friend of mine, Professor Driscoll, and I had an occasion to spend some time together, work together at Harvard University over a decade ago. And we were both working at that time for a summer leadership institute that does a lot of the work that we've talked about here today, working with religious organizations throughout the country, community development corporations, to address all kinds of disparities and issues surrounding equity, and public health and health equity is certainly among them. And so I want to introduce Quadrico's Bernard Driscoll, who is the Government Relations Manager for the American Urological Association, the premier medical association for the advancement of urological patient care. With nearly 10 years of government relations experience, Professor Driscoll has been responsible for federal lobbying efforts of different public health organizations, securing medical research funding and legislation for chronically diseased patients, which includes fighting cuts in cancer and psoriatic disease research. Am I saying that right? Psoriatic. As well as helping to draft legislation designed to establish a council of federal agencies, medical experts, and patients tasked with drafting and implementing a national strategy to combat prostate cancer. With that, I want to turn it over to Professor Driscoll and our illustrious panel.
Thank you, Cameron, for that introduction. As he mentioned, we go back almost a decade time together at Harvard. So I want to thank Representative Robin Kelly and her staff, Mia Keys, for the work of convening this commission on truth and reconciliation as we look, of course, at the diseases that in fact impact all people, but particularly people of color and specifically African Americans. And so I thought it best that before I introduce the panel, that we let some statistics for a moment sit in our mind. Black men in the United States suffer worse health than any other racial group in America. Black men live 7.1 years less than any other racial group. They have a higher death rate than women of all leading causes of death. They experience disproportionately higher death rates in all leading causes of death. Black men are 5 times more likely to die of HIV and AIDS. Black men have a higher incidence and higher rate of death from oral cancer. 44% of black men are considered overweight. And for black men between the ages of 15 and 34, the number one cause of death is homicide. Let's let that marinate for a second when we think about men's health and what that means. And so, I'll introduce the illustrious panel. Damon Christian serves as the Strategic Alliance Manager for Men's Health Network, which I also have the privilege of working very closely with Men's Health Network. Dr. Paul Michael earned his doctorate at the University of Miami School of Medicine. He completed his internal medical residency at the Cleveland Clinic in Florida as a chief resident and has a specific interest in critical limb ischemia. And then lastly, Dr. Neva Rubin Johnson is a dedicated physician
who has been an advocate of quality health care for all, especially in underserved and underrepresented communities. I think I'll just allow them each a 2-minute time limit to briefly discuss their roles in this concept of men's health and what that means.
Well, thank you. I want to thank Congresswoman Kelly and her staff for inviting me to speak here. It's an honor. I work with her office, and it's always a joy. So thank you. I also want to thank everyone here for listening and being part of the conversation. That's what it's going to be. It's going to be a conversation. My role within Men's Health Network is building coalitions and spreading awareness. So whether that's coalition with different lawmakers who are friendly to our message and want to spread awareness on men's health, or whether it's health screenings around the country, or it's building coalitions with fraternities or with different churches, anyone spreading awareness for men's health is my number one goal, and that is the focus of my job.
Thank you for having me here. It's a real pleasure. The goal here is to participate in this low discussion to raise awareness for a killer that is a silent killer. And the whole goal of our project called DREAM is to not only raise awareness, but to be that voice for those patients, to see what a toe ulcer really does to a community of people. And hopefully I'll be able to tell you more about that in the upcoming discussion.
Good afternoon. I'm the 119th President of the National Medical Association, who represent the over 50,000 African American physicians across the country and the territories and the patients we serve, which are predominantly African American. I'm also a general internist, and I just completed 31 years of practice, 29 solo private practice, and approximately 40% of my patients were male. And I've been married for 16 years to my husband on the front row. So I've been wife of a male patient. So we've got a few stories to tell about that.
Absolutely. Let's give them a round of applause. So we've talked a lot, I think, throughout the day with regard to health disparities, right? And when you think about the fact that Black men in this country go through a great deal, though I would add certainly Black women, I think, go through far more. There's often a lot of myths and expectations of what it means to be a man and what it means to be male. And I think that puts a lot of stress coupled with the historical trauma that is associated with. And so we know, of course, of the historical trauma that presents itself and shows up in some of the healthcare disparities. But let's consider for a second social constructions and the role it plays in men's health. For example, women are taught very early on to take care of their bodies, and they are trained from an early age, because of the female anatomy, to go to the physician's office. A boy, less so. Hence, it plays out and why men do not go to the physician's office as much as compared to women. So, Dr. Michael, who are the populations that you serve when you're considering men's health considerations, and how does these stigmas and misconceptions play into the work and the patients that you see?
So in your introduction, you touched about so many topics, and if I told you that every single one of those is related to the patients that I see, you couldn't hit it more on the head. So when you see a toe ulcer, okay, when you see a patient who doesn't have pulses in their feet, that is the end stage of a preventable disease. Although 50% of the problem comes from our parents who we cannot pick, the other 50 is preventable. And we can do that starting just by talking like this. So the reason why cardiologist was made fun of for being a toe doctor is because we were able to see as a team that the tip of that iceberg, that toe ulcer, is floating on top of every disease you just mentioned, from cancer, kidney disease, coronary artery disease, diabetes, hypertension, dyslipidemia, and mental health. Chop a man's leg off, okay, and watch what the depression rate does and mortality. At least twice a month, I talk somebody out of suicide, have to take a male patient, mostly African American in our community, hold him, hug him, and tell him he is going to be okay, and we are going to save his leg. So to cut a man's leg off, white or black, impacts the community in such a way that you can't even imagine. The healthcare costs, the disparities. So the whole goal of my career now has been shifted from opening up arteries in the heart to opening those leg arteries so these patients can walk and we build teams of specialists who put them together to offer that care to the patients.
Thank you. Damian, we know that 1.7 men, African-American men, are more likely to be diagnosed with prostate cancer, and they're 2.2 times likely to die from prostate cancer. And we should also know that this is Prostate Cancer Awareness Month. And so as some of the previous panels today talked about this issue of men's health, and when we think about men's health comprehensively, we also have to factor in our transgender brothers and sisters. So transgender women, from those individuals who are born male and transition to women, still have a prostate and can still develop prostate cancer as well as breast cancer. What role does mental and sexual health and screening disparities with regard to prostate cancer, STIs, and STDs, and the larger scope of men, which includes transgendered women, as well as transgender men, play in this larger role of health disparities?
Well, I think the most important word you said there was screening. So the United States Preventative Task Force has every so often they have a list of guidelines, screening guidelines, whether it's breast cancer, testicular cancer. This year they released their screening recommendations on prostate cancer. Mixed results. They went positive in one direction for men 50 to 65, where they said before it was a D, which means pretty much means don't do it. Don't do it. Yeah, don't do it. This is prostate-specific antigen test. It's a blood test, okay? But now it's a C, so that's improvement. But it's still a D for men 65 and older, and that is not good because, as we know, the older you get, the more likely you are to develop advanced prostate cancer. So we've seen from the government a real reluctance to really focus on men's health. Particularly, and that affects all men, black men especially, transgender men, or transgender females, I'm sorry. Born male but transitioning to female, they can still get prostate cancer, okay? And they're forgotten, just like pretty much all men from government agencies, just kind of pushed to the side. So we want to raise the awareness among all agencies, particularly focusing on men's health. So as we focus on men's health, as we hear the disparities, as we continue to allow the statistics to set in, what are the solutions? So what are the solutions, be it economic changes, systemic changes, lifestyle changes that we all can make? So Dr. Johnson, what models of care can black men and black families take from the provider's perspective, but also from an individual perspective?
Well, starting with an individual perspective is to start with, what you started out mentioning. What can you do for yourself? And what can you do for yourself? Can you eat better? I think all of us can do better. Can you drink more water? Can you eat more fruits and vegetables? Can you get more sleep at night? Sleep is real important. Studies have shown, cortisol levels are up if we don't get enough sleep, stressing our bodies out even further. So the things that an individual can do to better their health. And then, extend that out. What can you do for your family? Can you encourage your family members to go to the physician? Of course, you go to the physician, encourage your family members to go to the physician. Encourage your family members to eat better, to sleep better, drink more water, etc. And then your coworkers, because in all honesty, some of us spend more times at our jobs than we do with our family. And that's really your next closest community. And so, same thing with your coworkers. Are you going to a physician? Let's have some healthier snacks in the office. So, that's another arena. But you also mentioned USTPF, United States Preventative Task Force. And so those recommendations come from studies. Unfortunately, we aren't in those studies enough that those recommendations come from. So I'm going to speak personal level. My husband, okay, he's a prostate cancer survivor. 6 years, almost. Thank you. But if he followed the USTPF recommendations, which are also to consult a physician if you're between 55 to 69, I believe. Mm-hmm. What if he didn't have a wife? Was there a physician who said you're getting a PSA done every year?
PSAs from normal to abnormal were 14 months apart and went from 4 to 6. And then, the urologist rightly said, okay, we're going to check it in a month. And in a month it was 7. Okay? At this age, the proper thing to do, you don't jump in during surgery. It was 7, and at that point he said, okay, biopsy. Biopsy was positive, he went to surgery. We actually, I'll never forget because it's me, but also we got the biopsy results right before the 2012 presidential election, and he had surgery 3 days after President Obama won. So, never forget that. But, had surgery, his grade was actually higher on the specimen than the biopsies. So what if he didn't? Unfortunately, we can ask the question of what happened when you don't, because his brother just passed from metastatic prostate cancer in June at 61. Diagnosed at 60 with stage 4 prostate cancer. So probably was there when he was in his 50s. And after my husband had surgery, my husband told him, he needs to go to check. Told all his brothers, he's got 3 others. You need to have your PSA checked. And his story goes even further because he's got a strong family history of prostate and breast. And, our next trip is probably to a geneticist to do some gene studies. But, this is what happens, when you do and when you don't. Okay? And so we've got to get men in the study so we won't get recommendations like came out with USPTF. Because on this, do not agree. I stood on the floor of the House of Delegates at Illinois in June talking about this because a resolution about doing something to upgrade this recommendation came out on the floor. Another AMA member who's a prostate cancer survivor also spoke to this also. And I'm doing this talking about it 2 days after my brother-in-law passed. So those are the things that we can do.
So you mentioned a great deal of topics here, right? You mentioned clinical trials and the fact that there are not a lot of women, there are not a lot of African Americans, Latinos, etc., that are in these clinical trials. And you also mentioned the fact your husband is a prostate cancer survivor, congratulations, sir. But he had a wife who is an internist, who is a physician. This is for any other panelists. What can men do to take ownership of their own health so that there is not a woman or a female figure in their life encourage them to go to the physician? I mentioned earlier in terms of how we rear our children, right? We rear little boys and little girls vastly different. So what steps can men take, particularly those who are younger, the millennials, as well as older, to take ownership of their own health?
So I'll just start by saying, taking ownership is a personal responsibility, okay? And so they've got to be exposed to why they should and know that it's necessary. One of those tools that's come out for at least those who are employed is, you go to your job, you have to do a screening every year where you get your blood pressure checked. You have to go to a physician to do your blood pressure check, your blood sugar check, your lipids, etc. Found out in Chicago why they started doing that with the public agencies there, in particular from the mouth of the former president of Chicago Teachers Union, Karen Lewis. There's a statistic like 40% of members of Chicago Teachers Union have no physician. Male or female, no physician. So what does that mean? These are people who have insurance and no physician.
I mean, it's our job.
So that's a way to get them to a physician's office. But it's not just our job, it's families' jobs also. There is a model in Chicago for not my brother's keeper, but there's a Chicago Department of Health clinic that has a men's day every week to encourage men to come in to see the physician. There's a Bible there, so that there's some attraction to get men to see a physician. So, but men have to see the reasons why and understand the reasons why, like what you said before, in terms of what the end game is. You don't want the end game of losing a limb.
The story we described is our daily life. This is real patient care. There were 2 things that bring a man to the doctor, like we were discussing earlier, are his wife and his penis. Okay, yeah, it's for real. Yeah. So why does a man have to wait for the end stage, right? When the tires are burned out and the car is smoking, okay? And you're burned out on the side of the road to go see the doctor. It's ridiculous. So as physicians, right, we have to take ownership of implanting disease awareness at an early age in these patients, at school age. Just because you got normal pulses at age 10 doesn't mean you're going to have normal pulses at age 40. When 50% of the disease is asymptomatic, and you're waiting for the diabetes to burn your nose out on your feet, and you can't feel it at age 50, that can be prevented. Being diagnosed with diabetes at age 30. So they can't act upon something that they're not aware of. So I agree with everything you said, but we have to do our part educating at the school level, incentivizing our employees. If I love the people that work for me, I would not give them a paycheck unless they have a blood pressure check every so often. Why not incentivize these people? If you take a man's payroll, he's going to come and see a doctor, 5 minutes, get your blood pressure. If it's 200, why are you going to need 5 more years until on dialysis, with burned out blood vessels, to then seek medical care, which burns the health system out? Now it's not the government's job to take care of that. We could have prevented that with awareness and education.
I think a few things. It all goes back to what you said earlier, the stigma of how we raise our sons and our daughters. So there's this big boys don't cry mentality, rub some dirt. Boy fell down. I remember when I was a kid, my brother would teach me how to ride a bike. They used to make fun of me when I fell down because I would cry. I was like, what are you crying for? You fell in cement and didn't cry. So that kind of mentality will toughen out. But I think for us right now, our age, young black men and young men in general, we have to just start having conversations and saying it's uncomfortable, a little awkward. One thing I've done in my life, I started talking to my dad about his prostate. Dad, have you gotten your prostate exam? He said, oh yes, son, because I don't want you to die, Dad. Yeah, I love you. So we got to have uncomfortable conversations, but that will spur us. Like, men, when we're in a group, our group can positively push us or negatively push us. And we have to start making that a positive push for healthcare, because women do a much better job at taking care of themselves than we do. That's why they live 5 to 6 years longer than me.
It's interesting. I was most recently having a conversation with a colleague of mine, and this is a sweeping generalization, but there's some truth in it, in the sense that men love cars and enjoy cars. And most of the time, we all take care of our cars. We get them serviced every 3 months or so. But yet men do not go to the physician's office, to the doctor's office, as much as they take care of their cars. So if they can get their car serviced every 3 months, why then can't men go to a doctor's office every 3 months? So part of this conversation, we mentioned about ownership and personal responsibility. But we also know that there's a larger role that policy plays into this. And the United States Preventive Services Task Force has been mentioned a great deal. And we know what the United States Preventive Services Task Force is. It is a task force that is composed of primary care physicians that makes recommendations, screening recommendations for certain diseases, one of those diseases being prostate cancer. So what role does policy play in men's health, specifically, as well as the disparities that exist within black men?
Huge role. I'm going to touch on probably the biggest healthcare policy in the last 50 years, ACA. So ACA did a lot of good. Giving insurance to uninsured people is a good thing. I think we all agree with that. That's a good thing. It's kind of like we were talking about, we're not going to get rid of the whole thing, but it needs some major fixes. And one of them is, per ACA, there is what's called a young women's visit, where if you're a woman, once a year, if you're on the exchange, you can go to the doctor and you get a checkup. They check if you're in a certain age range, 24 years or younger, if you're older and sexually active, sexually transmitted diseases such as chlamydia or gonorrhea. Mental health is part of the checkup as well. There's no well-man visits in ACA. There's not. So that is a policy thing that needs to be changed immediately. I mean, that can save a man's life. And men are more likely to commit suicide than women. Black men are 5 times more likely to commit suicide than black women. And that's on the lower end. If you go out higher, if you go to Native American communities, white males, it's even higher. It's almost 6 times. So that's a policy, real definitive policy change that needs to happen.
From a policy standpoint, the reason why I'm here is not just to raise awareness for the disease process, but to the playmakers, right, who can actually make something happen. How do you treat a disease that nobody knows about? How do you treat a disease that is not officially recognized by the government and the payers? There's no code for critical limb ischemia. Yet it takes out more lives than any cancer except pancreatic cancer. We've talked about prostate cancer 11 times, mentioned in the conversation today. Do you know what the cost is of critical limb ischemia versus prostate cancer? over $100 billion more. Only one cancer takes out critical limb ischemia, pancreatic cancer, because it's a silent killer, just like critical limb ischemia. So we need Congress to recognize the disease state for what it is with its own code. That way the teams that take care of these patients are actually appreciated so that patients can find them. And then hospital systems, payers can actually allocate resources to these specialists to treat the patients. But if you're not getting paid and the patients aren't getting recognized, there won't be any therapy. So we're doing this in the middle of the night on the side gig. That's why I dedicated my career here. So this is not a side gig. This is a career, and we have to build teams across the country, create these amputation prevention centers that are holistically focused. Everything from depression to erectile dysfunction. So just that tip of the iceberg, there's a lot under it. And we need the government to recognize that.
Libby Johnson.
So in terms of policy, I agree 100% about ACA, and that is an excellent place that it could be improved. I think what's critical is that we talk about the policy. If we want to maintain it, we also have to talk about what we need to do to maintain it and make it better, and that's get out and vote in November. You know, I'm president of 501c3. I can't say who to vote for, but I can say go out and vote to make sure we have ACA here and hopefully to be improved, because depending on results, you know, it could be a totally different picture. And so policy plays a huge amount in terms of healthcare, in terms of this round. What has been good about ACA is that we've had some improvements in life expectancy because of ACA. I mean, that's the bottom line. We've had some decreases in complications of some common illnesses. Those things like heart attack and stroke have lessened to a degree because of ACA, because patients have gotten to their physician's office sooner or gotten in a physician's office so that their hypertension and diabetes could be diagnosed and prevent some, you know, in-organ complications, which critical limb ischemia is an end-organ complication. And so ACA has definitely brought about some improvements. You know, hopefully there'll be a change in who's in the governorship in Georgia so that they can have Medicaid expansion. Okay, because they don't have Medicaid expansion at this point. And so we want to be out there for people who are willing to support health policy that's going to help improve our health status.
Thank you all. So right now, I'm going to open up the conversation to the audience. Yes, ma'am.
Hi, I'm Stacey Mills, based here in D.C. In D.C., 97% of the population in D.C. is insured. So we're very fortunate in that way. Unfortunately, in our community especially, we have folks who don't go. So I heard someone mention responsibility, accountability, etc. And I'm actually at the point where I'm beginning to wonder if there should be some penalties. And that is not something I ever wanted to do. When I was in my public health program, one of my professors was like, do you think it required women to get pap smears to get their welfare checks? They'd get them. Well, certainly I don't want to go there. But are we at the point where we need to begin at looking at some other ways to get folks in to get treated?
So actually a few years ago in Pennsylvania, there was an entity, and I want to say it's a healthcare system that actually is self-insured. And what they did was they didn't punish their employees, they incentivized them to do what they needed to do. And so maybe the co-pays would be less or the deductible would be lower, but maybe that's the way, and they did see good results from doing that. And so maybe that's the way that, you know, we need to go. Instead of punishing, we need to incentivize.
So that population, incentivizing, I mean, they send out Walmart cards, H&M cards,
And if they're already incentivizing, I can't, I think it's, once again, the conversation with maybe just not that, but they, everybody's got emails and cell phones. So,
Okay. I guess you're gonna have to go to the mountain and ask the Messiah for the answer.
You're right.
Okay.
Why is it that black men, why is it that our colon cancer rates and prostate cancer rates are so high?
So disparities have been looked at in many different disease processes. And I can put the same map up of the United States with a bunch of different colors that show you care gaps. Latin Americans, Native Americans, women, African Americans. The bottom line is access to care. If I go into a neighborhood and I drop an amputation prevention center tomorrow, there will still be a care gap, and actually the split grows even wider when you provide access because of insurance care gaps. So we can put any blanket disease process there. So really, talking about education and awareness means having people actually do something about it. I go to many meetings, and they put up things like, here's the data, we have to do something about it. Why aren't there people out there presenting what we did about it? And that's what our team does. So you have to put teams together of people that care, that prove results, that the government can then say, okay, these are groups of people that actually get stuff done. Why don't we invest in these groups so we can have outcomes? For the male patients, you have to make the disease real. If you brought the auto industry, right? If you don't bring your car into the maintenance shop, you will lose your warranty. Okay? Why do kids put condoms on? Because they know what the results are. You make it real for the patients. Right? Why should you get your pulses checked, your blood sugar, your blood pressure in high school, in college? You have to make it real for them. Show them what the long-term results of that is. Positive reinforcement. Don't just scare them and take stuff away from them, but you have to reinforce them and educate them.
So to push this a little further, I live here in the DMV area, and in Prince George's County, Maryland, it has one of the wealthiest net worth incomes of African Americans in the country. But yet it also has the highest incidences of prostate cancer, colon cancer, and so education and income is not the issue. So again, it goes back to this issue of historical trauma, racism, and the disparities that exist. So it's a comprehensive question of solutions, the historical trauma, the racism that equates and equals the disparities that exist.
So if there's data that shows that those rates are higher because of people not going to the physician and you delve and you get the reasons why, and it's those things are not being counseled, et cetera. Okay, that's good. But let's talk about another statistic, obesity, and how that plays into how many cancers. And colon and prostate are two of them. Okay? And so we have to talk about, we're talking about an affluent county, are we eating affluently also? Are we eating a high-fat processed diet that's contributing to both of those? Processed more so and fatty with colon, fatty with prostate. Okay? And so is that part of what's going on with those two illnesses also? Hopefully in colon cancer, we're going to see some improvement with statistics over, I'd say, probably the next 10 to 15 years, because one thing that I believe USTPF has done is dropped the recommended screening to 45 for everyone now. It was American College of Gastroenterology, I think, had dropped to 45 for African Americans a few years ago, but now it's down to 45 for everyone. Part of that is because colon cancer is being diagnosed earlier across the board. You're having more people in their 30s and 40s being diagnosed with colon cancer, which is truly a preventable illness. Actually, colonoscopy is the only preventive test for cancer. Everything else is early detection. But colonoscopy, you take out a polyp, you've taken out a potential cancer. And so maybe in 10 or 15 years, we'll start seeing those rates of occurrence and also death decline also.
No, I think it's holistic. I think it's a little bit of everything. Yeah, whether it's systemic or whether, unfortunately, we know that black men are one of the least insured demographics in America. I think that plays a role. I think, once again, we're not having that conversation as frequently as we should about talking about our own health, our own personal health. I mean, it's our diet. We know that if you're obese, your likelihood of getting prostate cancer goes much, much, much higher. So I think it's a little bit of everything making this horrible perfect storm that's destructing our community, destroying our community.
You also have to tailor the therapy to the community. There is no blanket therapy for the country, okay? So in our community, it's a very strange amalgam of Mar-a-Lago is like 7 miles from our hospital, right? The Riviera Beach, only 5 miles from that, is one of the worst holes you could imagine, okay? So drive to JFK North Hospital. I call it JFK by the sea to make it sound nicer to people, so I should get them there. But half of my African American population, they're not even African American, they're Haitian. A quarter of those people don't even speak English. So there is no disease awareness program you are going to do in English that will target those people. So what do? You make a Creole one, and you learn Creole, and you speak their language. So we have a program called Bon Pied, Good Feet. Haitian women will not show up to the office if they think something bad is going to happen. Right? They're going to get their care at home with whatever home therapy they can get out of the refrigerator. So if you educate their community, right? If you tailor therapy to their families, and you bring their families in, that's how you're going to make an impact. So there is no magic bullet. We have to target them. Just the way we have medications that target genetics, right? We have to target therapy to the communities.
One last question, 2 last questions.
I'm Joseph Johnson, my wife is Dr. Most of us don't have the ability to have a doctor that tells you if you sneeze the wrong way, you gotta go to the doctor. But the thing that I found out when I was diagnosed with this disease is that we got it, took care of it, but a lot of people, and I made a speech at a church that I'm a musician at, to all the women in the choir, women's choir. I said, go home and tell your husband to have a test. They thought I was crazy. I told them 3 times in a row. 8 people from that place had this disease, and they got to take care of it. So I think that, in my perspective, that if somebody that has the disease went through it, can talk to somebody, I can, everybody should be able to do so. Thank you. I think my wife has saved my life.
So we've heard a lot about the barriers, the social determinants of health, and I guess my question kind of like loops back around. We've heard, as far as CLI is concerned, behavioral change that can make an improvement. I would like to hear from the rest of the panel behavioral changes that you think will improve the conditions that you were speaking on today.
So, behavioral changes that will help improve. I think it's starting early with, as was talked about before, and how we approach healthcare for boys. You know, it's equal for boys and for girls. I mean, boys are being taken to pediatricians, you know, for immunizations just like girls are, and that has to continue. You know, it doesn't have to be that they're treated differently than boys are. They shouldn't be. Unfortunately, you know, numbers of African American males in medicine is another issue. But I had friends who sought out male pediatricians for their sons to help with that. And so if you can, you know, that does help. And you know, in terms of them continuing to want to get care. So that could be another somewhat behavior change also. And, you know, in that vein, I saw a study came out a few days ago that said black men's health is better when they're more, you know, when they see a black male physician, when they're available. Of course, we didn't need to study the telescope, but we got one that did. So hopefully that helps.
Push on a little further. Do patients really care the color of the skin when they go to see a physician, or are they ultimately concerned about treatment?
I think it depends on where you are and who it is. You know, I've heard stories in Michigan where, you know, physicians of color or physicians, you know, East Asian, you know, were told by whites, you know, they didn't want to see them, they wanted to see someone else. I've heard it in the East Coast, I've heard it in the South, I've heard it everywhere. I don't think it's the majority, you know, but I think it does. It definitely does occur. We know about those occurrences.
So behavior changes, Dr. Mike. So we have to get physicians, right, to examine patients with their socks off. Nobody would let in my office while taking their shoes and socks off before getting in the room. Simple things, behavioral changes. Getting a man to understand that when he takes his car, we have the car example, to the dealership, you're not expecting the car to leave there with the tread being checked, the oil, the water level. Simple things that may seem silly later on that prevent catastrophes down the road. So there's tons of behavioral work that we can do. I love that topic.
And going back to the car analogy, because it's good. Okay, so when you have a car, you're going to do little things yourself to maintain it, whether it's change the oil, check the oil, check the antifreeze, put gas in it, wash it, wax it. Little things that you're not going to pay someone else to do, because that would just be ridiculous. Why don't we do the same thing? Why aren't we eating a little bit better? Why aren't we just working out a little bit, jogging once a week? Alone, we're walking, taking brisk walks, so like little things, building that up. No one climbed Mount Everest in one day. It took weeks to do it. Because I feel like if we're not getting to that point of it, like healthier lifestyles, we're chopping the tree off the top, but we're not getting to the root of the problem.
So we've talked a lot about truth and reconciliation, which has been the theme of this commission. We know what the truth, we've heard the statistics, but there are certain solutions that we've heard. The role that physicians play, we've heard the ownership that men, black men, have to take of their health. We've heard getting their families, their spouses involved. We've heard early detection, early screening, starting young, and we've heard diet. And if I wouldn't be the good lobbyist that I am, I would also recommend that there are some bills that we've been working with Representative Kelly's office on, sponsored by Representative Donald Payne, which is this potential office of men's health that looks at disparities. Right now, we know that there's an Office of Minority Health under Department of Health and Human Services. There is an Office of Women's Health, but there is no Office of Men's Health. And so this is a potential piece of legislation that will be introduced in Congress soon that will help to address some of the issues that we've talked about. As it relates to prostate cancer, there is the United States Preventive Services Task Force Transparency and Accountability Bill. That is bipartisan, Representative Bobby Rush and Representative Marsha Blackburn. And then you have the Prostate Cancer Misdiagnosis Elimination Act. So we know what the solutions are. We're here. I encourage you to go, write, get involved, and do the work that needs to do to address the disparities with regards to men's health. Thank you.
Thank you.
All right, let's do a round of applause for our panel and our moderator. I don't know, brother. I'm going to go to the doctor. I might go home today. I just want to, again, thank our panelists. Thank you so much for your thoughts and your comments. I want to thank the audience for their questions. And I want to thank Congresswoman Kelly and Mia Keys and all of her team for convening us here today. Before the panel leaves, we want to take a picture with you, so don't go. And I just want to say that this is not the end of the conversation. This is an ongoing conversation, and so there's more work to do, and we expect you to be engaged moving forward in these conversations. Thank you again for bringing us together, and we look forward to engaging with all of you moving forward.
Even though there's not a lot of people in the room, but can we give Cameron, he's been with us the whole time, a round of applause. And we could not have done this without Mia Keys. You are so phenomenal. Thank you so much. And you guys enjoy the rest of the conference. Thank you.